ECG, but echo in the ambulance. This is indeed what we did as a test already some years ago, where our residents could have the echo images on their smartphones before the patient could arrive. And as we know, the distance is no longer an issue. We can communicate these images from Munich to New York and vice versa. But if we think about it, there are many things we could do in the ambulance. We could even do some blood tests. We could apply already some treatments and orient the patient. Again, when I was a young doctor, when we tried from the ambulance to call the hospital and say, okay, please be ready. We will need a neurologist for a cerebrovascular accident. The answer was, yeah, come in, we will see as soon as you are here, we will call one, don't worry. That's not the right way to go. We need to be prepared to receive that particular patient. So that needs a better telecommunication system, and we are, of course, getting there. I reviewed this paper for the Lancet, where they gave antibiotics in the ambulance for septic patients. Wow, that's interesting. Oh yeah, the title is interesting. But this was not sepsis. It was fever. Patients, had an 8% mortality. Less than 10% were admitted to the ICU. So I told the authors, no, it's SIRS, fever and tachycardia, that's SIRS. So it's sepsis. No, give me a break. And we don't want to give ceftriaxone to all patients with fever in the ambulance. But the Lancet wanted to accept it, it will be cited, and they invited me to write the editorial to warn people about this particular paper. But the point is well taken. The point is well taken that for really septic patients, for long distance, it may be worthwhile taking blood for blood cultures and giving antibiotics. This is not rocket science, but it's interesting. Just observation that if noradrenaline is administered in patients with severe shock prior to arrival in the emergency room, it could bring some benefit. I'm not sure we need a prospective randomized controlled trial on this. As we discussed the day before yesterday, we need to correct profound hypotension right away. So, indeed, it makes sense to start noradrenaline early in the ambulance for profound shock patients. We spoke about the plasma transfusion in the ambulance. Could give blood. This is a positive study showing lower mortality when blood is given in the ambulance. This is a negative study, but they reached the hospital right away. I mean, it was not really. So in all these studies, we need to see how long it will take to bring the patient to the hospital. Of course, if the hospital is next door, there is not much we can do in the ambulance. But if we are in the middle of Australia, it's a different situation. So let's skip ED triage and let's go to the workup and intervention. For severe cases, I truly believe in a strong collaboration between critical care medicine and emergency medicine. In our institution at the Erasmus Hospital in Brussels, we are proud of having what we call a shock lab. The word is the word. It may not be the best word we could find, but that's what my predecessor found. The point is that this is not a shock room in the emergency room. No. It's a room which is in between the emergency department and the Department of Intensive Care with 4 beds. And the important point is that patients are managed by both ER team and ICU team. Nurses work together, doctors work together. The patient may come from the emergency department, the patient may come from the floor, the patient may come directly from the ambulance, like here, a patient in cardiac arrest, and we start ECMO right away in this particular patient. It's the kind of room that allows us to move fast with a sufficient number of people, being for trauma, for sepsis, cerebrovascular accident, myocardial infarction. Clearly, in the future, robots will help a lot, and I have no time to review all the applications of robots, but there is a lot to say. I alluded to the endotracheal intubation made by robots, but it could be insertion of IV lines. It could be entire CPR with CPR robots. So maybe it will no longer be necessary to teach some people how to do CPR if we have these systems widely available. And finally, disposition. In the future, we will have better biomarkers to help the doctor at the middle of the night to decide whether this patient could go home or should remain in the hospital. Or it could be a combination of variables. Or we may find a better variable. This paper just came out showing, and I invited the authors to write it for a collection I was responsible for, but this is sepsis biomarkers, but it could apply to other conditions. How, from big data, the artificial intelligence system could select the best variable or variables. Telemedicine will change our world. The surgeon could appear on court while still in the operating room. Well, kidding aside, it's clear that the surgeon can operate in the distance. That will change our lives, because if it's just a few meters away, it could be very further away. I wrote this piece with Slutsky and Gattinoni on intensive care medicine in 2050. And we said, well, they do quite a lot of surgical procedures here, but there are hardly any surgeons. All surgery is done remotely, with surgeons only present in case of exceptional technical breakdown. That means that one surgeon can operate in several different institutions and from anywhere. It's not only surgery, myocardial infarction. Should we still transfer a patient to this institution where they have invasive cardiology? Or can we do it here? We just insert the catheters and the robot may do it for us. And then, indeed, the proper PTCA will be done by a cardiologist being located elsewhere. Simulation will change so much. This is one of the best centers in the world in Strasbourg, France, but we will see the virtual reality appearing for the surgeons too, for anybody doing procedures. And digital twins, of course, will help us to simulate better. So, telemedicine is not only to help remote regions of the world. It's a big question. Will the hospitals become smaller or bigger? I already addressed more or less the population going to the emergency rooms, but this is also an important question, because we could actually transfer all complex cases to large institutions, or we could keep them in a small institution, but help the doctors by telemedicine, by supervision. So we wrote this piece, Dr. Osterman and I, saying, you know, there is a potential benefit in centralization, to have access to specialized centers, sophisticated technology, etc. But there are also some downsides. You need to transfer the patient. It may take some time. The family may not help, may not like it. Even the people in the hospital may be less and less trained. So decentralization could have its advantages if we can learn from others, from the big institution. But, of course, it's not as if the patient was in the larger institution. Yeah, AI will change our world. In the field of diagnosis, of course, we all know that AI can help to identify skin tumors, but now, in the radiology context, it's huge. In many centers, X-rays are interpreted by an AI system. No radiologists look at the thorax X-rays. But in the future, we will have radiology available everywhere. Bedside CT scans with automated analysis. Bedside MRIs. Yeah. Bedside MRIs will come. And with automated analysis, we can already have breast ultrasound examinations. Echo, as I alluded to the day before yesterday, will be monitored automatically. One of the participants yesterday asked me, I have some difficulties sometimes to use the VTI to assess the response to fluids. I can understand that. But in the future, the probes will be there on a chest cuirass, and these data will be collected automatically. Did you look at this? That's fantastic. 9 months ago or so, it was presented with big noise. It's an ultrasound sticker developed by MIT that can allow you to have echo images 20 centimeters deep in the body, and it's put on the skin. Look at this. It's a very small wireless wearable Doppler ultrasound that could help you to guide the fluid administration, evaluating the patient's response to fluids. Okay. We all know that the EKG can be automatically analyzed, old stuff. What I found interesting is that we may still make progress, and AI may tell us more about the EKG, like dyscalcemia and many other things. In terms of therapy, after all, if we think about our intellectual process for reaching a diagnosis, yeah, AI can do it pretty well. Of course, under our supervision, of course, definitely. But it could help, and it will help us in the emergency room of the future. Think at antibiotic therapy. Shall we call an antibiotic consultant? What will he or she do? He or she will collect all this information about the patient, about the environment, about the bacteriological data, and from there, will propose 1 or 2 or more antibiotics at this dose by this route. Of course. So, if it happens in the ID doctor's head, why not in a computerized system? And this was done in Salt Lake City in the last century already. And it showed that it works with a benefit from the patient and for all. Artificial intelligence is particularly useful when we have to deal with multiple variables. And in complex cases, obviously, we will have to do that. ARDS management is a good example. We need to check tidal volumes, plateau pressure, the driving pressure, elasticity, and now the new thing is power. Put everything together. And so you can calculate power and see if it goes up or down when you change something. Wow. This can be done quite simply by an AI system that could drive the respirator for us and also take care of the hemodynamic alterations that could actually follow what the changes we make. So, this is more than protocolized care. This was already published a few years ago. It's a first initiative looking at should I give more vasopressors or more fluids. It was imperfect, but it shows the way. It shows how an AI system at some point collecting all the information could tell you, yeah, in this case it's probably better to increase the doses of noradrenaline. Or maybe you should do another fluid challenge. That could be an interesting information. And finally, with the modern monitoring systems we will have in the ER, like on the floor, we will have a better monitoring of the respiration, a better monitoring of the heart, even without the patient knowing it, because it's under the mattress. I visited the Army hospital in San Antonio, where they developed a system that could identify hypovolemia before any tachycardia, of course, much before any hypotension, but before you can see anything. Of course, as you know, this is a model of lower body negative pressure to reduce venous return to the heart, and there are systems on the finger that could help us to identify hypovolemia early on. And all of this, of course, without wires, even EEG. The future will be wireless. The monitoring systems will no longer have to be connected. And they will be miniaturized, as we reviewed in a couple of recent papers. And this will allow to evaluate trends and prevent catastrophe before it could occur. Already in the ICU, so it could be in the emergency room as well, which patient may actually crash. So better alarm systems will be part of our world. Finally, how big data will help us to assess the effects of some therapies. There are three requirements for this. One is that we must standardize the collection of our data. One is that we need to use a common language. And one is that we need to cope with ethical concerns. And first of all, we must make sure that our systems are interconnected, that we don't need to change the system when we go from the emergency room to the ICU or the operating room. And this requires some efforts. And this is true for the entire hospital and groups of hospitals, as all the data will come together in a very, very big computer. And as we know, data collection for big data, it's not only variables, very precise variables, it's also the information that we can obtain by mining the notes. And this is a big issue. We need to use a common language. Hypoxemia is not hypoxia, and yet at many meetings we hear doctors saying, the patient has a low PO2, it's hypoxia. No. And we learned about it at this meeting. We said, you know, when you go to the Everest, as Hugh told us, you can have profound hypoxemia, and the lactate level hardly increases, even though the person is hyperventilating like hell. There is no tissue hypoxia. There is hypoxemia without hypoxia. So, likewise, when people say, oh, the patient had ARDS, so there was hypoxemia. No. Some patients with ARDS never develop any hypoxemia. They have altered gas exchange. We may have to use a high FiO2, high PEEP level, whatever, ECMO, but the PaO2 could have remained normal all along the evolution. So I will skip this because I'm reaching the end. Oh yeah, one point. I have an interest in blood transfusions, and I know many of you too. I would like to emphasize that this stuff of 7 grams per deciliter or 70 grams per liter is really wrong. We all agree that we should not give blood only on the basis of a hemoglobin concentration. And yet, the prospective randomized control trials were all conducted on the basis of a hemoglobin level. But that's not what we do. So, for this study many years ago, we tried to put some other indications, like altered tissue perfusion, coronary artery disease, diminished physiological reserve. We had long discussions, and we could not find anything better. So it shows that it's very difficult to take it into account in a prospective randomized controlled trial. But observational studies like ours here suggest that maybe in some patients getting a blood transfusion may be beneficial. When you look at databases, And this has been shown by others as well. And this is the latest ICON database, more than 10,000 patients, suggesting that in patients who are very ill with a high Apache 2 or a high SOFA score, blood transfusions may actually be beneficial. So that's typically what artificial intelligence can help us with. Looking at big data, we can look at patients who are transfused a little bit, much, not at all, and from there, make some interesting conclusions. So this is really personalized medicine, and as I say today, it's a big topic in critical care medicine. Instead of applying rigid protocols, we can use personalized approaches. Hurdles for the last minute. Costs, in my opinion, is not an issue because we will need less personnel and improve the quality of care. Of course, if there is a new treatment coming in, it may take a while to collect enough information with this new treatment. Think at the new medications we used in COVID-19. You cannot immediately apply it through an AI system. You need to have enough experience so that the AI system can indeed apply this information. And sometimes there are some bad interpretation. Bad interpretation because the system is clearly needs supervision. And sometimes it may look at things which are not really there. Remember this Facebook apologies from an AI system? It is very sad indeed, and there are others about data collection in people with other skin color, etc. And this brings us to the ethical aspect. But the simplistic associations. Of course, the use of vasopressors is associated with a worse outcome. So a simple AI system will say, don't use vasopressors! Wait a minute, it's not the vasopressor that is associated with higher mortality rate. It's the underlying condition of the patient. So that's how we need to work together, doctors and computer scientists, and this should be supervised. Responsibilities, of course, like the car, which drives by itself. We need to address these questions, but that will be done. And finally, breakdowns, hacking, that will have to be addressed. The role of doctors, let's be careful. We should not stay behind our screens, but we should still go and see our patients and put our hands on patients. But doctors will help in planning and in limitations in some interventions. So, we are making progress. We will make much progress. We should not say, AI, no, I don't want that. That would be ridiculous. We need to work together, doctors and computer scientists. Look at this, my friend Fabrice Brunet, who was in Paris, who is now in Montreal. They have a school of AI with 3,570 students. Wow. Looking at all these aspects and contributing to progress. I hate ChatGPT because when I type my name, it says that I am emeritus professor. I am not emeritus professor. It's nowhere on the internet. It's not on Wikipedia. It's nowhere. And it says I am emeritus. So it's a bit stupid from time to time. It needs supervision. But artificial data, big data are here to stay, and we should remain humans. We should control the system, but we will make a huge progress in emergency medicine and elsewhere. I never think of the future. It comes soon enough. It's attributed to Einstein, but many things are attributed to Einstein. Anyhow, it's very clever. Thank you very much.
Hello. So are there any questions? Someone at the back there. It's a roving mic. She's coming to you.
Thank you. Good morning. My name is Mark. I feel like I'm ready for the future. I'm definitely awake now. There were excellent aspects of the future, and I like that you came back to the doctor at the very end. I wonder, there was a bit of a crowded picture where you had lots of specialists in the center. There was an ER doctor, and I heard there are places in Europe where you need an ENT doctor to stop a nosebleed. You need a neurologist to see a patient with headache or vertigo, or maybe an orthopedic doctor, anesthetist to do a shoulder reduction. What do you see the role of the emergency specialist evolving in Europe?
Yeah, I think the emergency medicine doctor will continue to have an essential role in trying to identify where the problem lies. It will, again, be helped by AI systems, but still, as you say, when the patient comes in for headache, the patient doesn't need to see a neurologist. You need to quickly appreciate the situation. But in many conditions, this can be done quite fast. I was impressed by my visits at the Mayo Clinic. I went a couple of times. I will go again soon, where the doctors are paid to be doctors. And so there is a team of non-doctors, healthcare associates, who will come into play and help the doctor to remain concentrated on its main tasks. I don't know how it is in your country, but in Belgium, doctors spend time writing, ticking boxes, putting certificates on it. This can be done by other people. So organization is really, in my opinion, really a big thing. And that's what you can see in hospitals like the Mayo Clinic, where they are superbly organized. And it does not diminish the humane aspects, because the doctor will see you for just a short time, will say, okay, now you will go with this particular nurse who will tell you more about your disease. And then you come back to me. If you have some additional questions, come back to me. I am not running away. And I think that's a good thing. Now we will go and see the EKG, we'll look at a quick cardiac workup, and then you come back to me. So organization, I think, is a key word. And at least in the emergency rooms where I go to, I feel that the organization is not good enough. There is much to do there.
Thank you so much. A pleasure having you here, and hope to see you again soon. So we move to Jakob Karlsson now, who's pediatric intensivist and anaesthetist in Stockholm in the Karolinska Institute. He's got a big interest in hemodynamics and the oxygen delivery in children. And he's going to speak to us this morning about the extremes of oxygen delivery in children.
All right, I'm glad I brought a microphone anyway. Thank you for the invite. It's great to be here. Fantastic place. A lovely little city already. When you come in, you see the beautiful Matterhorn here on the picture, and that's an extreme environment, definitely. But sometimes it's not the environment that's extreme; it's the patient. So for the next 20, 30 minutes or so, we're going to do a little breakout session where we're going to move from the big sick to the small sick, essentially. So the topic's going to be extremes of oxygen delivery in children. It was either that or avalanche injuries in neonates, but turns out there ain't a lot of that going on. So I'm Jakob Karlsson. I'm a pediatric anesthesiologist and intensivist. Are there any other pediatric anesthesiologists here? Hardly anyone. Fabulous. Means that I can say pretty much anything I want with very low risk. I work at the Karolinska Hospital, brand new. We got a brand new helicopter. They're very proud of that one, with ECMO capabilities and whatnot, and we'll get back to that later on in the talk. So I want to divide this talk into essentially 3 sections, where we will look at some of the key factors that we now talk about in modern pediatric intensive care and anesthesia. So the first thing I want to do is I want to talk to you about, are there any differences between children and adults? I usually say, contrary to popular belief, children are actually small adults. I know that's hard to swallow, but there's some truth to that. Not always, though, which will become apparent later on. The second part we're going to talk about is, given that, is there anything that's specific about pediatric ABC? Is there anything we need to modify and switch based on that knowledge? And then for the third section, we're going to move into a bit more translational research part, where we'll look into some of the systems that we've developed to monitor hemodynamics in children, because it turns out that can be quite tricky, mainly given the size. So how do we know that we're doing the right thing? So the first part, any differences between children and adults? Well, I think it's safe to say that it is. If you walk around a pediatric intensive care unit, you may come across something like this. So you got a heart rate of 127, mean arterial of 41, SATs 80. In an adult ICU, I haven't been there for many years, but I'm assuming this would require some kind of attention, maybe get some attending in, maybe even call a crash cart in. For us, I'm not going to do that. As a matter of fact, I'm going to go back to the coffee room and kick back and have a cup of tea, because this patient is perfectly balanced. There's nothing I need to do there. In fact, any other numbers than this would seriously jeopardize the oxygen delivery for this kind of patient. This is a single ventricle child with complete mixing of systemic and pulmonary venous blood, so it's different physiology. So the newborns are different, even older kids are different. This is data from a 3-year-old girl, 15 kilos, that we monitored. Never mind why she was admitted or why we did this, but when I look in hindsight on all the monitoring, I put a little bracket there so you can get the normal level, which is about 100. So the blue line is saturation and the other one is heart rate. And for many, many hours, this girl was in a low heart rate and low saturation state. So you had levels almost down to 87 for many hours. And the problem here is not so much hypoxia, it's because this child is about to wake up and the iPad is running out of batteries, because that's my daughter when we flew home from Canada, where I used to work in Montreal. So as you can see, children are a bit different, but they are robust. And they are robust for various causes. They have mechanisms that protects them from physiological deterioration. That doesn't mean that they don't end up in trouble, and kids do have their own ABC. And that brings us to the second part of the talk, which is there anything specific about pediatric ABC? And I think it essentially boils down to 3 things. It's going to be size, scale, and time kind of thing. So even though the principles are the same, handling and managing an airway is the same, massive bleeding is the same, but it's smaller. You're going to need specialized equipment to deal with a 2.5 kilo baby with a congenital airway cyst like that. In a massive bleeding, that's the aftermath of a massive transfusion in a 3 kilo baby, where we used 1 bag of red cell, 1 of FFP, and 1 of platelets. That's massive for us, but I switch her blood volume at least once. So the scale and the size is smaller, but the principles are pretty much the same. And time is the third aspect. And time, think about just basic physiology in a newborn child. I don't know if you remember this stuff, but you got the oxygen dissociation curve. When you're born, it's kind of left shifted because they got the fetal hemoglobin and they don't want to release any oxygen, right? The other thing is that small kids have small lung volumes. So everyone in here, even a newborn child, usually have a functional residual capacity, which is the lung volume at the end of expiration kind of thing, where the gas exchange occurs, of about 25 to 30 mLs per kilo. If you paralyze and intubate the child, whether it's roadside, helicopter, trauma room, doesn't matter, you instantly drop their FRC from 25 down to about 10. So you got a hemoglobin that doesn't want to play around, you got small lung volumes, also they burn more oxygen, but 2-3 times, but 2 times when you're anesthetized, because you don't need that much oxygen when you're under anesthesia. So time is going to be a critical factor. They desaturate fast, and time is essentially not on our side. So how are we going to deal with that? Well, we want to, particularly important this becomes when we're dealing with airways. And for the airways, you want to buy time. And how are we going to do that? Well, first of all, you need to make sure that you don't waste time not seeing what you want to see, if that makes sense. The other thing is that you want to have enough time to be able to do that. And you can do that. I mean, the time is so critical for kids that you can even say that you're used to the ABC thing. So ABC, for children, for the small children, I would even go as far as saying that A stands for airway, B, airway, and C, shockingly, airway. I mean, that's how important it is, and that's always when you end up in trouble with these kids. So you want to make sure that you can buy time. And the way you do it, at least the principle that we use, is by combining a variety of techniques. You're going to want to use, for instance, videolaryngoscopy. Not always for the same indication as you have in adults. The other thing you want to do is you want to add supplemental nasal oxygen while you intubate. And the third part relates to keeping the heart going. So you need to have something that keeps the heart pumping while you do this. Atropine is usually what we would use. You can use anything else, really. And for the videolaryngoscopy, it's not so much that it may be technically difficult. It can be, although that's pretty rare, actually, unless you deal with syndromic kids. It's more the fact that, and I know you come from the adult side, you've heard this a billion times, but you have to get the tube in on the first go. And the reason is that if you don't, it's going to be really difficult to re-recruit them and ventilate. And you'll end up in a very bad circle where you're doing your second attempt, you're bradycardic, you're hypoxic, and you're starting to run out of options. So we routinely use video for kids under 3 months, just because. And doing that, the technology is the same. There's nothing strange there. The other thing you need to do is you're going to want to add high flow nasal oxygen. Actually, it doesn't have to be high flow. It can just be normal flow. Recent studies that, and you do that while you intubate. So you stop your ventilation, assistance there immediately, put this thing on, and that has huge implication on your safe apnea time. In an infant, you can now stretch up to 60, 80 seconds without any complications. New England study last year, Australia, NICU babies, standard laryngoscopy, high flow versus no oxygen. They went from 50, which is kind of low, but remember, these are 1 kilo babies, so it's a bit stressful, right? You got to get it right. Up to 70 by adding oxygen. And then, actually, it's so interesting to be here because Switzerland is kind of a mecca for this. In Bern, you have Thomas Riva is a pediatric airway ninja, and he just published in Lancet a combination of high flow oxygen and video. And he got it up, and that's a liter per kilo normal, doesn't have to be high flow humidified. And he got it up to 90%, which is pretty good. You want to be in the 90% crew, you don't want to hang around the 50% guys. So this is why I have personally no problem whatsoever letting a first-year trainee intubate a 1.7 kilo baby with a video, and it usually works very well. The third part, now that we covered video and supplemental oxygen, is that you want to add something that keeps the heart going. And if you think about that, I know there's a lot of talk about oxygen delivery and consumption, but the flip side of that is actually CO2 removal. So you think you got your normal, ventilation going on, and let's do that. And then if you add some atropine, you can speed the process up quite a lot. So the CO2 that comes out is going to be, of course, related to ventilation, but also how much CO2 do you actually deliver to the alveoli. And it turns out that actually the CO2 removal is so tightly coupled to the pulmonary blood flow that we can utilize that to estimate the effective pulmonary blood flow. And we'll talk more about that when we talk about advanced hemodynamic monitoring. So that's why you want to give some atropine. Now that you have the tube down, you're going to want to ensure that you have a good breathing. And in children, usually the lungs are pretty good. Neonates don't tend to smoke. They don't do this kind of stuff, so they get usually healthy lungs. But the margin for error is small, so you may have a short distance down to the carina. And here's where I think some of the modern technologies has helped a lot, because we use a lot of ultrasound for these kids. So you put a high frequency linear probe like that over the sternum, and you get a picture like this. I deliberately choose a poor picture because people always bring their best pictures to these meetings, but this is actually what it looks like. So you put it on and you would see the sternum. And the good news about this is the smaller the baby, the easier it is to get a good image. And these are the kids where you really need it. So you're going to identify the plastic tube that's going to come up to the left. And then you actually have the aortic arch over there. And the bottom of the aortic arch is exactly where the right pulmonary artery is usually. And that's the carina. So the distance there is usually the distance to carina. And then you combine that with, of course, your standard lung ultrasound. And actually, lung ultrasound in small children is really difficult. You can see lung sliding, but that's pretty much it. So that pretty much covers breathing. When it comes to circulation, sometimes it's straightforward. There's no talk about it. And it's obvious that this kid needs some kind of volume, right, because he's bleeding a lot. However, it's still a question of how much, and just like the adult guys, we're struggling with what do we want to give. And traditional way of estimating cardiac output or circulation in kids is to evaluate blood pressure. And that's totally fine. All of you guys know that pressure is just a proxy for flow, really, and it's actually a pretty poor predictor of how we deliver oxygen. And in kids, you have to add another aspect which is related to monitoring and measuring technique, because it depends a lot on where do you measure it and how do you do it. It becomes very obvious when you're in the cardiac OR. You may have a situation like this, newborn baby. You may have a non-invasive pressure mean of 35, right radial of 48, and aortic arch of 44. So it differs between 35 and 48, depending on where you measure it and what method. So how are you going to know what's normal? How are you going to relate that to oxygen delivery? Yes, there are these normograms, and you should use them. You should stick to whatever departmental practice you have. But we thought a lot about this, and there's got to be other ways of actually estimating cardiac output and oxygen delivery in children. And this has been a big black box in the whole pediatric care, really. But we thought a lot about it, and we had to dig really deep and go really far. In fact, we went very far out in the pulmonary vascular tree. This is a synchrotron image done with a particle accelerator in Grenoble, which is on the French side of the Alps, that we did on a rabbit in a project many years ago. And it shows a high-resolution image of the outer part of the vascular system. And you know, in those areas, you got blood flowing through the alveoli like this beautifully. And we started thinking that there must be a way of evaluating the interplay between the ventilation and circulation there. And it's possible. You remember I showed you a picture of atropine where you increase the pulmonary blood flow, and that relates to CO2 removal. So we developed a system called dynamic hypnography, really, for advanced hemodynamic monitoring in children. And if you think about the CO2 that you have in the alveoli, if you can estimate that, which you can with some mainstream volumetric hypnography, and you can also get a good idea about end capillary arterial CO2, which is really what your end tidal CO2 tells you about, but you can do that in a little bit more fancy way. If you realize that these things are interrelated, then you can actually estimate cardiac output. And the way you do it is you change the respiratory pattern. So what we do is we give them 6 normal breaths, and then we add 3 breaths with a short expiratory pause. And under that pause, you change the alveolar CO2. So it's really nothing. You can see the ventilation goes on, and then it stops for a while. And it stops. And under those short breaks, you alter the alveolar CO2 a little bit, and that alteration is related to the pulmonary blood flow. So we can signalize that, and we can evaluate it with MATLAB, and then we can get breath-by-breath estimation of cardiac output and some other stuff. And remember, in kids, you can't really do anything. We can't get a 5 French introducer sheet and do transpulmonary thermodilution. It ain't going to happen. So we need something. And it looks a bit like this. This is an example of a child. I hope it works. And as soon as you start picking up data, it'll give you numbers. This is a 6-kilo baby. A 6-kilo baby would usually have a cardiac output about 120, 150 mLs per kilo per minute. That's where you would set your ECMO run, for instance, and it makes about sense. So have a look at this thing. That's cardiac output. And it's going to park upwards some around 0.85 liters per minute, which is perfectly sensible. The other thing we can do, thanks to the alveolar gas equation, which you all know, you can actually calculate backwards and get an idea what the mixed venous oxygen content is, and then you can estimate the mixed venous saturation without the PA catheter. We're evaluating this now, and this means that for this child, for instance, it doesn't matter what the blood pressure is. I have a good cardiac output and a good mixed venous oxygen saturation, so I don't need to fiddle around with things. We also actually get something called ELVCU2, which is probably equivalent of FRC. So dynamic hypnography gives us a very good idea about cardiac output, mixed venous oxygen saturation, or at least a proxy for that. And it's a good way of monitoring oxygen delivery and consumption. Now, being at this meeting, of course, what's the application? Well, outside the pediatric world, I think it'd be awesome to do advanced hemodynamic monitoring in any intubated, mechanically ventilated patient, essentially. Without the need for any training or calibration. So that pretty much sums this thing up. So remember, kids are pretty robust. They are different, but they are robust. The other thing is when you deal with the airway, use video, use oxygen, and use atropine. And try not look so much at mean arterial pressures. Try and relate it to oxygen delivery and cardiac output. If you want to know more about this, you can check out the Safe Thoughts webpage where we do a podcast on this kind of stuff. You're more than welcome to ask me about that. And that's pretty much it. Thanks.
Thank you, that's absolutely fascinating. Any questions from the audience? Don't see that. Now, I've got a question. It's a little bit off the topic, but I always find that kids are incredibly resilient. Cardiac arrest in an adult, you get them back and you go, yeah, they're going to end up neurologically compromised, or you think, after this time, I'm never getting that adult back. Kids I've had 30, 40 minutes in arrest, and they come back neurologically intact. Why do you think that is?
Okay, so that depends a little bit on the age of the child, but like I said, they have a lot of physiological factors. I mean, if you look at a newborn kid, when a child comes out, essentially they come out, they just came off ECMO, right, because they've been on the placenta, so that's a pretty big deal. They're now breathing room air. We've measured, not we, but some of the guys in my lab looked at the epinephrine levels actually in the blood of these kids, and it's about 1,000 to 10,000 times higher than the normal situation. They're always born with suprasystemic PA pressures, PDA, ASD, so and they do fine. All they need is 30 minutes to crawl up and get the first breast milk. So they're wired, hardwired, and designed to survive. The other thing, the question is, of course, when you look at older children, the honest answer is I don't know, but they usually have a much more forgiving physiology. They don't have vascular stenosis, they never smoke. They have a very pristine and nice system that tolerate a lot. So this could be some of the explanation. But like I said, they are pretty robust, and it's really hard to, I mean, they survive most stuff. Let me put it that way. That doesn't mean, you should set the bar higher than that. But I mean...
You're saying that kids are super easy because they're an easier group. I get that. I mean, adult anesthesia is much harder.
All right.
Brilliant. Thank you. Any questions? Lovely. Thank you so much. That was fascinating and really interesting. So our next speaker is Mike Tipton. He works in the Extreme Environments Lab in Portsmouth, and he's going to talk to us about immersion and survival from immersion. He's got years and years of experience in this, and fascinating to hear what your thoughts.
That's a nice way of saying I'm old. Thank you very much for the introduction, and thank you for the invitation to come here. I'm from the Extreme Environments Laboratory, where we do work that ranges from microgravity space through to hyperbaric, heat, cold, but particularly cold water immersion. In fact, Portsmouth isn't renowned for its space program, so my question at the start is, how do you think we do space research in Portsmouth? We'll come back to that, I'm sure. The title of my talk is The First 5 Minutes of Cold Water Immersion, which is where my expertise sits. After that, it gets a bit fuzzy. And what that means is I won't be talking about hypothermia. People don't become hypothermic in cold water in less than 30 minutes, unless they're under some special circumstances that I'll mention later. It'll be quite a different talk. I'm a human and applied physiologist, and one of the things that's been a theme through this meeting is most people in this room get somebody presented to them that's already had a problem. I actually create the problem, and then we look at what happens. And that means we play right across what we've called the drowning chain of survival, right from the initial prevention through to where you guys do your magic, which is up here in providing the resuscitation and the critical care. And I'll try and give you a feel for that as I go through. Drowning is a process, and some of us believe that that process starts with ignorance in the community, and the best way to address that is to get rid of that ignorance. And of course, it's quite a lot cheaper to do the preventative medicine at this end of the chain than it is to try and correct things when they go badly wrong. So why are we interested in immersion? Well, here's why: because 1,000 people at least a day drown. It's a major killer of children. It's the biggest killer of sportsmen undertaking their sport, for example. Alcohol involved in about 40% of drownings, and males outnumbering females 2 to 1 in that regard. So it's a big problem. In the UK, we lose somebody about every 30 hours at one child a week. Let's get the definitions out of the way. There's the definition of drowning. And you'll notice 3 outcomes: death, no morbidity, or mid-morbidity. And terms like, although you still see them used, near drowning, secondary drowning, dry drowning, have been obsolete now for over 10 years. Drowning is a process that I keep emphasizing, and that process can go on beyond the period of immersion. So this is a medical student wishing he'd done art or maths or something different. And if you just lower him fairly slowly into water at 10 degrees Celsius, you'll see something like this. A picture's worth 1,000 words. So this is maximum breath hold time. This is water at 10 degrees Celsius, and this is a mock-up of a Bell 212 helicopter. This guy is trying to hold his breath as long as he possibly can. He's wearing heavy normal clothing. He manages 5 seconds. You can see there a gasp and uncontrollable hyperventilation. He then makes his exit. You have to sit still for about 13 seconds when a helicopter ditches to allow rotor blade activity to stop before you make an egress. Here's the same person now wearing the protection that was provided at the time against hypothermia, calculated to give 90 minutes protection against hypothermia. Gives 1 extra second breath hold time. This is because we've been preoccupied with hypothermia in this area. I blame the Titanic, but there are other reasons. But in fact, this is the most dangerous response you see on immersion in cold water. We called it the cold shock response a long while ago, last century. And we called it that not because of any medical connotation, but because it's just a shocking thing to happen to you. And it's driven by skin receptors. And because I'm only talking about the first 5 minutes of immersion, I'm only going to really talk about skin-evoked responses. But because we're 5 cylinders with a sphere on top, about 50% of the tissues of the body are within about 2.5 centimeters of the surface. So we shouldn't underestimate it. And we've got 3 times more cold receptors, about 0.18 millimeters below the surface of the skin, than we have warm receptors. And they show a classic sensory dynamic response to a change in temperature. And this is what you see. So here we are, pre-immersion, respiratory frequency, ventilation, end tidal, heart rate 96. This guy is a little bit excited. He's a young, fit, healthy individual, but he knows that this is about to happen because he saw the previous person, which is a fundamental methodological error, but that's the way it goes. So when you lower this person into the water in the way you've seen, there's your cardiorespiratory response, which we call the cold shock response. You're seeing hypertension as well. 5 minutes into the immersion, this dynamic response, these receptors have adapted to their new environment, and that drive to the cardiorespiratory system has been reduced. Now, I'll just talk a little bit about prevention, because this particular slide, this underpinned a major drowning prevention strategy in the UK. So we know that you've got this. At this time, you've got no control of your breathing. Just about the worst thing to do at this period is to start swimming, start thrashing about, raising your arms. 3 to 5% of the human body will stay above water if you do nothing, and that hopefully is this bit. As soon as you raise your hand, it becomes that bit, which you can't breathe through. So it's a really good idea in the first minutes of immersion to stay absolutely still. And so this is the neurophysiological correlate of it's okay once you're in, okay? But this is a very dangerous period, and then things calm down. So the best thing to do is stay still on immersion. So you team up with the Royal National Lifeboat Institution in the UK and really smart people who can turn that one graph of data into a campaign. And that involves things like telling people when they drink, how many people die when they have drunk and then they go drown, or what the volume is that you're going to aspirate. You can get big posters put up in London railway stations, and you can produce something like this.
Everyone who falls into cold water has the same instinct, to swim hard. But cold water shock can make them gasp uncontrollably and breathe in water. Then they drown. But if they just float, until the cold water shock has passed. Then they'll have a far better chance of staying alive.
We call it from lab to life-saving, and it's really impressive the way people can take that and produce that. And does it have, the problem with the preventative medicine end of stuff and these campaigns is they're relatively straightforward to do. How do you know you're having an impact? You guys know when you've saved a life or when you haven't. The way we find out is people volunteer. They write to you and they say, I think that advert saved my life. And I think we're up to about 50 unsolicited emails in that regard at the moment. We've also had a bit of a success with our emergency services in that when you now ring 999 and ask for the Coast Guard, depending on circumstances, they'll tell people to instruct the person in the water to float. So that's another benefit. Back to the physiology. So here's the table of the information that I just showed you on the graph. And first minute of immersion, 114 litres of air being shifted in and out of the lung uncontrollably. Just to contextualise that, lethal aspiration of seawater, 22 mils per kilogram, about 1.5 litres. Fresh water, about 44 mils per kilogram. So that first gasp of 2 to 3 litres, you may well already have crossed the lethal dose for drowning because there's a wave splashing on your face, you fell and went under the water, or you're in an inverted craft. Even 2.2 mils per kilogram is reducing your PaO2 significantly and increasing the pulmonary shunt. So this is a significant insult. There is, you can read the academic literature about the difference between seawater and freshwater drowning. Functionally, if you're going to retrieve someone, it's the same problem you're addressing. It's hypoxia, hypercapnia, and acidosis. By slightly different reasons. Saltwater because the osmotic potential stays in the lung, freshwater is absorbed but washes out the surfactant, so you get collapse of the alveoli, atelectasis. Excuse me. So what happens if you just continue and have people go under the water? So now you've got the cold shock response, which is evoked by the skin receptors, as I say, but as soon as you get the head under the water, you invoke a response that was reported even earlier than the cold shock response, which is the diving response. So that's the vagal response initiated by the ophthalmic division of the trigeminal nerve, and of course, in many ways, opposes the cold shock response. So the cold shock response, you'll see in head-out immersions, increases heart rate and force of contraction. The diving response, which is a parasympathetic as opposed to sympathetic response, vagal, decreases heart rate and the force of contraction. So there's an example of both of those. Here's the cold shock response in terms of the tachycardia. I always say, you know you're doing a slightly dodgy experiment when you replace your medic with a priest. And here's the bradycardia. Now you're seeing a bradycardia here of about 33 beats per minute, and that's because this is a helicopter pilot wearing his immersion protective clothing. The only bit of him that's really left exposed is his face, which of course means he's getting quite a lot of stimulus for the diving response and less stimulus for the cold shock response. Here we see some studies we did on diving babies, where you see a more profound diving response. We lose that response as we grow older, and we evoke it later. It takes 30 or 40 seconds for this to be evoked. It occurs more quickly in children and is more powerful. We had the ECG on the back because those of you who deal with pediatrics know that if you put it on the front, they pull it off again. So you have to have it on the back. And it's not as simple as which one wins. Here's the ECG trace with a breath hold of somebody just under the water, and they've just broken their breath hold. They've come back to the surface and broken their breath hold. And you can see the confusion in the rhythm caused by this competition between the sympathetic and the parasympathetic inputs into the heart, the diving response and the cold shock response. It's a remarkably reproducible way of evoking arrhythmia and dysrhythmia. So if we do a head-out immersion in young, fit, healthy individuals, we'll see an arrhythmia probably 1 in 100 immersions. If we add a maximum breath hold and a face immersion or coincidental face immersion or wetting, that goes up to around about 82%. Young, fit, healthy individuals. And it's idiosyncratic. If you do this again to this individual, you'll see the same ECG profile. Here's another one here. Again, you've got the pneumotachograph trace on here, so this is a breath hold, breaking of the breath hold. and you're seeing the changes in the rhythm that, again, are reproducible. The arrhythmia occur normally within about 10 seconds of the break of breath hold. So we've looked at the dorsal medullary nuclei, and this is following immersion for 39 degrees Celsius for 2 hours, and using CFOS staining. And there's no stain in the areas known to be responsible for cardiorespiratory integration. This is what happens when you have an 8 degrees 60-second immersion. So this area is now lighting up. So this may well be the neuroanatomical correlate of what we're calling autonomic conflict. Here's the traces I just showed you. You can reproduce that in an isolated rat heart. We do that with colleagues, Prof. Mike Shattuck and the team at King's, perfused with a constant background of adrenaline and noradrenaline and 1-minute periods of acetylcholine. So you're simulating that sympathetic drive to the heart. And you're seeing almost exactly the same rhythm changes as we see in the human with the addition of torsade de pointes. As I say, we've called it autonomic conflict. We know it's a very reproducible way of producing an arrhythmia, but so, for example, we've measured 25% of people undertaking helicopter underwater escape training show an arrhythmia or a dysrhythmia, but we're not, they're not dying. There has to be additional factors, predisposing factors, that will increase the likelihood of those initial arrhythmias descending to something more serious. One of those things, for example, is long QT syndrome, and we know there's a whole bunch of drugs that can extend the QT interval and increase the chances of seeing this particular problem on immersion. So the practical side of that, the message that goes out is avoid coincidental face immersion and long breath holds. So this is a really good place for getting autonomic conflict. Anybody who's been in a mass start in a triathlon, which I have, in fact, I'm in there somewhere, knows that it's a really good way of having to extend your breath hold. You've already got a sympathetic drive. You've now got a parasympathetic drive put on top of that. And you also get angry. And anger is, thank you, and anger is one of the things, one of the emotions, the emotion that simulates autonomic conflict. And we're seeing it in other areas, including altitude. Let me just show you this now.
It started as a sled ride along the ice-coated rock on the shore of Lake Michigan at Wilson. A slip, and 35-year-old Terrence Tontlewitz of 3818 West Montrose and his 4-year-old son James were suddenly in the near-freezing water. A cross-country skier had seen the incident and had come to help, but he could not hoist the man up the 6-foot rock wall. The child, meanwhile, had disappeared under the ice. The fire department arrived with ladders and desperately needed manpower, and the man was hauled up, out, and to a waiting ambulance. That left a child somewhere in the murky, ice-clogged water. By helicopter and special van, fire department scuba divers sped to the scene, wasting little time in donning rubber suits and air tanks. But time was running out. The child had already been under the water for more than 15 minutes. Time after time, the divers surfaced. Nothing, they shouted. But then, 5 minutes after they entered the water, the divers nodded. Success of a sort. We're sick. Child had been underwater about a half an hour, and we had thought there could be no hope for the boy's survival. But he lived, though it would be a critical case for some time to come.
A few interesting things in that video, not least the interaction between the emergency medical services and the local media. But also the other thing to note is how disabled the father was in a very short period of time in ice water. I mean, must have been incredibly motivated to do something, but was brought out after 10 minutes. And that's because of peripheral neuromuscular cooling. So nothing we're talking about today involves hypothermia. It's all peripheral, and it's all either cold receptor or peripheral neuromuscular cooling. There we go. So drowning takes about 2 minutes. This is Faina's work. And I just put it up there because we want to try and understand what happens with these individuals that go under the water. You know, obviously, that as you cool the brain, you extend its hypoxic survival time. If you get it down to around about 22 degrees Celsius, you can extend this for around about an hour. Excuse me. So what about these prolonged survival? So water temperature above 6 degrees, you're looking at the longest survival time with full recovery of about 20 minutes. Once it falls below 6 degrees, something happens, and then you get up to the current record of 66 minutes of survival with recovery. And you won't see this listed as a factor because this is a step function. It's not a linear relationship. So people will say water temperature doesn't affect outcome. It does, but it affects outcome once temperature gets below 6 degrees Celsius. The other common factors in these prolonged survivals are they tend to be small children or adults, fresh water, body temperature has fallen, and water temperature is lower than 6 degrees. I just want to make a point here because, of course, this gets stuck in the search and rescue community's mind that this can happen. This is 43 cases we found out of thousands and thousands of drownings. So it can happen, but it's not common. Mechanisms, it can't be surface cooling. You simply can't cool quick enough from the surface to lower the brain temperature. You need to go from 37 down to about 30 to extend the hypoxic survival time from about 5 to 10 minutes to about 20. What we have proposed is it actually is the drowning process that cools you. You're taking cold water in and out of the lung, you're cooling the heart, you're cooling the carotid artery supply to the brain, and you're selectively cooling the brain. Which means when you turn up, any other measure of core temperature is not going to have a prognostic value. It could be 7 or 8 degrees warmer. Do we have any evidence for that? Well, Al Con's work in Seattle shows that fall in carotid artery temperature, 2 minutes of submersion in fresh or salt water, 7.5 to 8.5 degrees fall in that temperature compared to 0.8 in a head-out control. So this is selective brain cooling over that 2-minute period of the drowning process. So what's the outcome? What's the practical outcome? So you turn up at the scene, start the clock when you turn up at the scene. Don't believe what people tell you for the reasons we've heard already this week. Is the water warmer than 6 degrees? Yes, it's warmer. You've probably got 30 minutes. Fine. Is it colder than 6 degrees? Is it warmer than 6 degrees? No, it's not. It's colder. Extend that to 90 minutes. And you can see that enshrined in our National Operational Guidance Program. We start the clock, dynamic risk assessment. Is the water very cold? 30 minutes. Go on, is it young or small child? 60 minutes, go on to 90 minutes. So again, this is the practical output of the applied work. I wasn't going to put any bullet points in for reasons fairly obvious, but there's a theme running through this meeting of fondue and vomit, which are almost interchangeable as far as I can tell. So I thought I'd just better tell you a little bit about that. So diffuse pulmonary edema, gastric distension, like air or water, and as a consequence of that, about 89% swallow water. Vomiting is the most frequent complication during drowning resuscitations. Greater than 65% of victims who need rescue breathing will vomit. 86% of those require CPR. The current advice is don't bother with Heimlich maneuvers, abdominal thrusts, etc. Finger sweep as necessary. And what about the prognostic indicators? They're here, you can read them for yourself. Note the 6 degrees there is, if it's below 6 degrees, that's a good one. But submersion time of 5 to 10 minutes. Death or severe neurological impairment, 0 to 5 minutes, 10%, and then it shoots up to 56% when you get beyond 5 minutes. And by 25 minutes is close to 100%. So they're the kind of timings. I've seen those kind of timings repeatedly this week in terms of getting things done soon. Because people are suffocating for these reasons, then obviously the goal is to provide oxygen as quickly as possible. Every minute CPR delayed, there's 10% less chance of success. You do the things that you do, 5 rescue breaths, so you include rescue breaths in the CPR here. Intubation, if indicated, high inspired oxygen and PEEP. There'll be a lot of froth and foam, ignore it. The ventricular fibrillation is rare in drowning, less than 10% in the literature, so don't waste time playing around with AEDs. By all means get one, but your primary objective is oxygenation. And then speedy evacuation. And the transport to hospital, pretty much in every case, unless there's virtually no indication of the aspiration of water. Secondary drowning doesn't exist anymore. This is just the continuation of the drowning process. But when somebody has aspirated water, they can respond with an outpouring of fluid into the lung, and drowning can take up to 4 hours. So the current advice is to watch for 8 hours. No case in the medical literature of a patient who underwent clinical evaluation and was initially without symptoms, deteriorated and died more than 8 hours after the incident. That's my summary. That's 2 of the 3 things I want you to take away with you. The other one is that I work with a really good team in Portsmouth at the Extreme Environments Laboratory. If you want to know any more about what I've said, it's all published, so you can find it here. I'm around for the rest of the day. Thank you for your attention. You sound surprised.
I think I'm that's better on my own now. I can't. No, I am.
Oh, yeah.
I think I'm on now. Any questions from the audience?
I've told you everything I know. Okay, so how do we do space research in Portsmouth? Any ideas? Well, you can do it like that, but we don't. Although we do in a way. So one of the methods, which is a fairly new one to Europe from Russia, is dry immersion. So we've just finished a study with the European Space Agency where you lay somebody on a plastic sheet that's over water. They're in a plastic garment, so they stay dry, but they're actually in an immersed environment. And the suggestion is you can get the same changes that might take many days in other circumstances. I don't want to give the other way of doing it, in as few as 5 days. So we've just been looking at that with 18 ladies. One of the problems with all these fields is the data that we base some of this advice on tends to be white males experimented on between 9 and 5 o'clock on a Monday to a Friday in high-income countries. And that's just worth shooting through every paper you ever read, because quite a lot of ferries, for example, go down at about 10 o'clock at night. So where's the circadian variation impact on this? What happens if your accident occurs in the middle of the night? So that's one. The other way I'll tell you is bed rest, but that's 36 days of laying in bed. And not students love it. They just take to it naturally. So the 2 methods that we've been involved with Professor Igor Mekovic in Slovenia, bed rest, and now with ESA, dry immersion.
Now, I have a question for you as well, unless anyone else wants to jump in, because obviously there is someone here. The roving mic is coming to you. Whilst the mic's coming up, the next question I want you to answer after this chap is when it comes to taking patients out of the water, there's a lot of stuff about trying to bring them out horizontally. And I saw in that video, I mean, understandably because of the situation, he was just pulled straight up. How important is that?
It depends on the circumstances. So this year I've done the first 5 minutes. Next year I'll do 5 to 10 minutes. And then eventually we'll get to circumrescue collapse, which is what you're talking about. Yeah. About 20% of people who go into water die just before they're rescued. It's a really strange phenomena, but the search and rescue guys turn, same in avalanche and in other scenarios, and their condition deteriorates at that point, and they have a problem. And it's been reported right back into McNulty's report on medical services in the Second World War. It may well be a vagal wave that goes across the body as people relax in the knowledge that they're going to be rescued, and the rescuers can make that worse by telling them to relax, that we've got you. You can't say the opposite and say, you're probably going to die, but you can encourage people to continue to fight for their survival, and we've done that. The situation you're talking about, if somebody is hypovolemic, hypothermic, cold myocardium, baroreflex is suppressed, and at that point, you come and you lift them out of what is essentially a hydrostatic squeeze supporting cardiac output, venous return, and you now hang them up vertically. Don't be surprised if they have a problem with their arterial pressure maintenance, and that'll affect the heart or the brain. And there's lots of examples of that. But they have to have those preconditions. If they've only been in the water 5 minutes or 10 minutes, then get them out, because the danger of them drowning far exceeds anything that's going to happen when you take them out of the water. So if they've been in a long while, they're hypothermic, hypovolemic, semi-conscious, be careful how you get them out.
Thank you.
Increasingly popular to go swimming in the sea in winter, or like ice bathing. Do you think you can train yourself to be able to, people say they enjoy it, which is difficult to understand, but to make your body like accept it more, or are they all lying to us?
This is being live streamed to the internet, where thousands of people go open water swimming. No, you can definitely habituate the body. We've done all the experiments on that. I didn't mention them. But one of the things that was relevant to discussions that were being had yesterday is one of the ways of reducing that cold shock response is with psychological skills training. Mental imagery, arousal regulation, self-talk. You can also get people to run about 1 kilometre further in the heat by those interventions. But there's also the physiological intervention of habituation. So as few as 5, 2 or 3 minutes in cold water will halve the cold shock response. 14 months later, it's reduced by about 25%. That's as long as we managed to study it before people said, I'm never coming back to this lab again. So, and the people that do open water swimming, yes, there's lots of claims, and a placebo effect is still an effect. And so, we don't know. We have hypotheses as to how this is working, anti-inflammatory stuff, immune function, et cetera, but none of that has been tested. On the other side of the coin, the hazardous side has been well researched.
Anyone else? Well, in that case, I look forward to hearing between 5 and 10 minutes next year. Thank you so much. One of the reasons we're all up here is because of the beautiful town that we're in and the beautiful mountains around us. And one of the reasons the conference exists here is because of Zermatt, their support, and also the environment that we're in. So our next speaker is Gerold Biner, and he's the CEO of Zermatt, and he's going to give us a pilot's perspective on the mountains.
Good morning, ladies and gentlemen. Are there any pilots in here? No, that's good. Fixed wing, that's good. So I can basically tell you my experience. It is a big honor to have this opportunity to present you here a little bit our work, our company here. I guess more than half of you have been here earlier. And when I yesterday asked Paddy, what shall I say? And what would you like to hear? And I said, maybe you can talk a little bit of the extreme situations and how you handle it. But I would like to show you a few slides and tell you a little bit more about the story and how it became to what we have right now. So that was rescue missions in the mountains in the 30s. That was not a barbecue. That was, you see, very limited medical sources and supply. Then it went on in the 40s, so a little bit more technical stuff to do the rescue missions and bring the casualties and the patients down. And the big changer, gebe ich dir, Luca. The big change, I would say that's the biggest change in alpine rescue was the introduction of an airplane or an helicopter. So that was definitely a game changer, and it helped to save a lot of time to bring the casualties and everybody who need it down to the valley and to the hospital. Today, of course, we have worldwide a complete different situation, and I would like just to tell you a few information about Switzerland. We have a big coverage. The big player is Rega, who's covering, I would say, 80% of our territory. And we are down in the southwest corner, 2 companies basically operating from the lower part. This is the French part, Air Glacier. And in the upper part, we have 3 bases where we do rescue missions, and if we need support, we have it from the northern part, but also from Italy, from the Protection Civile and the Gendarmerie in France, where we can go across the border without any problems, and that's pretty good, and that's the way it should be, you know, if somebody needs help. So, a little bit facts and figures. We have 2 Bell 429s. This is the demand from our regulator, EASA, who is asking for twin helicopters, even though after a certain height there is a need of a single engine helicopter, or when we have employed all the rescue helicopters, we have up to 50 missions per day, and everything is parallel. So you never know what kind of mission is next. And therefore we are happy to intervene also with the single engine helicopters, because the philosophy is, and I think this is why you guys are here, you are very high ranked specialists, and the most important thing to help people is to bring medicine, medical know-how to the site. And we are just a transport facility basically. But of course, it has to be in a way that we have a very good teamwork, and therefore we can employ all our helicopters immediately when there is a need. Just transform them from a passenger helicopter into a HEMS helicopter or a search and rescue helicopter. That's a little bit what we are today. About 130 employees, 3 bases, turnover, 2,000 rescue missions. That's it's not too bad, actually. We have on 2 bases a 24-hour shift. And other than Rega, who is basically founded by the foundation, 1/3 of the population of Switzerland is paying voluntarily $50, and with this money they are creating a situation that in Switzerland the whole helicopter rescue services are run without how do you call it, subventions. So that's a pretty unique thing, and it's very good. Here we are small, we have to cross subvention what we earn during our other operations. 20%, and that's the cash cows, are commercial air transport, where we do heli-ski, where we do sightseeing flights and taxi flights. This is where we build up our young generation of pilots. They get the experience on these flights. Then the majority, 60% of our activity are sling load operations, like here on the Klein Matterhorn, 3,900 meters above sea level, and you see this is the highest construction site in Europe, where we did, for this particular pylon, for this mast, we were flying 6,500 concrete flights. So you can imagine you are high up, you are always exposed to temperatures, to fog, and this is the situation and the location where you gain your training on job. These pilots doing 10,000 sling operations are the same doing at night or during very difficult meteorological conditions, the difficult rescue missions, and they are not sweating when they have to do a hoist mission or when they have to put a rescuer or a doctor somewhere in the scene with a 100-meter line. Only 20% of the full activities are rescue missions. Like you could see, about 2,000 rescue missions. Numbers are increasing, and it's quite a big task. May you just go forward a little bit, because I do not want to use too much of time. Maybe if you could just go halfway into this film. Not possible. Good. Okay. Then let's keep on going. So that was earlier, you know, that was the beginning. Jet Ranger up on the Matterhorn at 3,500 meters. You can imagine these pilots, they were pioneers. Nobody told them how to do, and it was an amazing what they did. So they gained a lot of experience. 1968, our company was built. This gentleman in the middle here, he is our president. He's still alive, 93 years old. He was the one who brought the medicalization into the Zermatt company and basically also into Switzerland. Thanks to him. He's a pharmacist, and he always put all his strength into the development. Like you can see the back here from Pax. These were developments made always during bad situations or bad experiences, and he was the one who always pushed us to go forward and to go better. He was also the hoist operator during the first hoist operation in the famous Eiger Nord phase in the 70s. So he was not only doing the hoist, operating the hoist, he was also taking pictures. That's the Spider in the Eiger Nord phase, where they for the first time dropped a mountain rescuer, and that was also, of course, another milestone in the development of mountain rescue. That's the first direct rescue mission out of the Nord phase. That's the dead bivouac on the Eiger Nord phase, and the pilot was Günther Ammann. 70s, so you know that's 50 years ago. They also did the cable car evacuation, so they were really the high pioneers. And this gentleman on the right, he was the founder of Rega. At that time was called the Schweizerische Rettungsflugwacht, on the Mittelegi with the famous aloe tree. So we developed everything. We were, and still are, member of the ICAR. I don't know if somebody from ICAR is here. I used to be the president of this International Commission for Alpine Rescue. And out of this commission, we were called also to perform rescue missions, not only in the Indian Himalayas, but also in Nepal. But since 1990, we are operating in Manali, a heli-ski base. At that time, in the 90s, we just put everything in a pallet, flew it down to Delhi, assembled the chopper, and flew up into the Himalayas. That was quite a challenge. And today, we have quite a good operation, and this is important for us as a pilot, and this is a high privilege as a pilot, because beside the experience you gain on during sling operations, here we have quite often a problem that we are operating on our limits concerning weight, and this operation in Manali gave us also the exposure and the possibility to gain a lot of experience in high altitude flight. What we learned there since 1990 is what we put into our training syllabus for the young pilots, mountain training. I had the big opportunity to hold Well, and also pilots, for us it is an exchange of experience. And the same is the fly in the Himalayas, because we go up to 5,000 meters. Besides having fun during skiing, it is a very high demanding skills you learn there, and this is what we try to give to all these young pilots doing rescue missions then afterwards. These are the guys from Swiss Economic Forum. I don't know, somebody's laughing because they most probably won't. They will come next month. I was just back from Dave to get my license done. That's the biggest nightmare I've ever experienced in my life. This is since 20 years, the only thing that has changed in India are the offices. Offices are nice, but this is where we came for this Out of that experiences, we were called a couple of years ago, 2005, to perform a rescue mission on Nanga Parbat, and this is a crazy story. We had this guy from Slovenia stuck in a hole at 6,500 meters, 2005. Thomas Humar, he was one of the biggest and greatest climbers in the world at that time, but he could not go up and neither he could go down. And we were asked to go down there because they knew out from the ICAR committee that we have a helicopter in India, which is 200 kilometers away. So they asked, can you not take this helicopter and just do the mission? We said, yes, we would love. But Musharraf and the Indian, they were telling us since 50 years, they allow sugar to go across certain boundaries here between Pakistan and India. So they will never allow a Swiss pilot flying an Indian machine, flying into Pakistan and save a life of a Slovenian mountain climber. But they said, Musharraf said, don't bring your helicopter, we have the same, just get your material. So this gentleman with the beard, this Bruno Jelk, very famous mountain rescuers, and that one on the right used to be our deputy chief rescuer and warden of the Hernley Hut. They said, bring all your material, but first we will try with the Pakistani pilots. Due to the lack of experience, you see, they used the wrong material. They had elastic, regular climbing ropes, no communication systems, and they almost crashed during this rescue mission. But finally, they could save him. We just arrived in Islamabad, and we had to turn back. During ICAR, we met this gentleman we saved, and we had a coffee, and he went off to Annapurna to do some very crazy stuff. And on the end, he said, give me just your number. I call you when I'm back from Annapurna. And then I gave him his number, and I said, Thomas, no problem. Wherever you are on this planet, just call me when you have a problem. And that was a big error. Because 5 years later, he was stuck in Langtang Lirong. And of course, he was stuck in a position where nobody else could climb because he wanted to do a first on Langtang Lirong. And he could simply call on his sat phone that he is in deep trouble. And to deploy a helicopter rescue mission from Switzerland to go into Nepal was almost impossible. And we lost 2 days. And finally, unfortunately, that's how we found him. He lost all his gear. He had a broken leg, and this time, unfortunately, we had to fly down his dead body. Simon Antematten, one of also very famous climbers at that time, he's now a helicopter pilot here in Zermatt. He decided to go it the easy way up into the mountains. He performed this rescue mission You see that was on 14th November 2009. So we decided to bring in these people and have an exchange of experiences. We also invited some governmental people that they could see that we use the right gear, the right material, the right communication system. And so out of this crazy
Das ist die Geschichte der Bergretter im Himalaya. Die Geschichte über den Traum von Piloten und Rettern in der Welt der 8000er, eine Rettungsstation aufzubauen. Dafür fliegen sie ans Limit, bis auf 7000 Meter.
Ja, es wird nicht einfach, mein lieber Freund. Es wird nicht einfach.
Sie trainieren und testen in dünner Luft auf knapp 6000 Metern in eisiger Höhe.
Ja, geht schon. Man muss einfach langsam schaffen.
Sie retten Leben.
We did rescue missions on Manaslu. This is Manaslu, Camp 2, where
Aber oft kommt jede Hilfe zu spät. Es ist aber auch die Geschichte einer Tragödie, als 2 Bergretter bei einem Einsatz tödlich verunglückten. Trotzdem halten sie an ihrem Traum fest und verlieren ihr Ziel nicht aus den Augen.
And it was quite a difficult task to finish that. Today, these people are performing up to 80 helicopter external cargo missions above base camps. I don't know if you have seen this film from this Nepali guy who just did all 14,000 peaks within 6 months. There was a rescue mission on Annapurna, and that was the team we trained 10 years back. For me, one of the biggest experiences was to fly. I thought I was one of the first pilots ever landing on Camp 2. I learned that there was in the late 70s, an Italian pilot, that's Camp 1, who did some landings up on Camp 2, unfortunately he crashed, especially quite probably. Did some today, all pilots are helping locals, Sherpas, but also the finding that they do not have to go through this convoys when they have people suffering from haze, HAPE, heart attacks or injuries, that they do not have to go through this convoys full and they pick them up at Camp 2. These days, up to 50 missions are flown all the time up in Everest region. So, I'm good in time, right? Good. So, it looks very nice and funny, but of course, we can only operate as a team. So, the pilot is part of the team. The paramedic is part of the team. The paramedic, he plays a very important role. He can support either the doctor or the pilot. But like I said on the beginning, the most important thing for us should be to bring the right and qualified medicine onto scene. Because if you are laying down on the ground somewhere, what do you want? You want painkiller. You want that this pain will stop. You want to get into a warm area, and you want to get into the nearest and best hospital possible. And this within this golden hour. That's the target. That's your task. Our task is to bring you safely onto the scene. And there, many people, they think, they just, nice sunglasses and the smallest piece of a helicopter is pilot's brain, so they're not too intelligent. So they just like to fly. They're like taxi drivers. But basically, everything we learned out of this experience you have seen is on one page. And this is why people or pilots all over the world, they come here to share this experience for us. And I will just briefly go through, because you will not remember everything. But basically, what we do is we do a flight preparation before the day. We go for the worst situation. Where could I go the highest? And basically, what we need is the zero fuel mass, because when I can hover somewhere with a certain weight, then the difference is always fuel. So whenever I do an approach, the pilot, he just have to watch the fuel gauge, and then he knows, yes, I have enough power, or no, I have not enough power. So pilots, they think about this because they do not want to suicide. They do not want to die on a mission. So they try to give the best. And maybe this is not spoken between the pilot and the doctor or the paramedic, but the pilot has to prepare himself. Then these are the embarrassing checks, that you are not doing an error which is costly. If you have the twist grip not in the correct position, then you can create easily a damage of $250,000 within 2-3 seconds. So this is why we said, keep it simple, 4 points. Every pilot can remember those 4 points at the time. So just keep it simple, stupid. When we go to a site, most of the time, we don't know where the next mission will be. So we had to establish something that the pilot, he can have in certain phases just to check the right things. So we said, identify the landing zone, check the altitude, because if you turn around and you come back, most of the pilots, they have the tendency of descending. And then when they turn back, they lose their target, and they have a hard time to go back. Check fuel, you see. And then we take the decision of the approach axis. Which axis do I go in? And there also just 4 small points. And sometimes maybe it's also good to know as a doctor on a helicopter. Did he see that obstacle? Did he see that the environment, that there were people, there were things on the ground? That's the next one. So this is for the approach axis. Define the approach axis. And there also, keep it simple, vole, wind, obstacle, light, environment. And then 4S, size, surface, surroundings, and shape. If a pilot is doing that consequently, it takes him maybe 5 seconds, but he has checked everything which is important to do a landing or to perform a landing on an accident site, regardless where you are. That's basically it. And then, of course, in final approach, we have a certain stage where we check a few things, also very easy as a pilot, where you take the decision, now I would like to go in, and this is where the pilot should really stay and commit what he has decided. So that's basically how we can handle difficult situations. If a pilot keeps calm, and you guys sitting in a chopper, you know and hear exactly. When the voice of the pilot is changing, you know exactly, oh, now he is in a difficult situation. That's the departure briefing, emergencies, but that's basically everything which you need to be calm in very difficult conditions or rescue missions, and it's regardless if you go overseas on a vessel or if you go up on Everest Base Camp, it's always the same. That's the experience we have, and I wanted to share with you. And before I go back to work, I'm open for any questions.
Thank you very much. It's always humbling when you see a true expert, you make something incredibly complicated sound so simple. But that's fascinating. Any questions? So I have a question for you. In this conference, a lot of medics, paramedics, and associated sort of medical people, we're always looking at risk. and we're trying to decide the risk for the patient stuff, but there's very little personal risk to us. But in these missions that you undertake and some of those amazing rescues in the Himalayas, there's got to be an element of risk to your machine, to your life. What is an acceptable risk? How do you calculate that and decide?
I would say the risk analyze is varying. So there are so many little tiny points. The most important thing for me is that you should not take too much risk and that you are concentrated on the job you have to do. And we are taxi drivers. We bring medicine onto the location and that's it. We are not deciding about death or life. That's maybe the doctor's decision. Also difficult.
I think that's very humble. I mean, if you've got somebody stuck on the mountain, you are deciding.
Yes, of
because
course.
You can't risk yourself.
Of course, we are human beings, and we have a lot of pressure. And when you know there is somebody you might even know, which is in a very bad situation, and if you don't react in time, he maybe lose his life. So that's the point where you should be focused on your task. And this is exactly where you have to stick. And this is kind of a plan, having a checklist, being focused and concentrated on your task. At each stage of the flight, simple 4 points you have to check. And then take the right decision. And this is kind of the risk assessment we do. And there also you have the possibility on final to say, no, it's too risky, I go around. Or I can just simply fly to that spot and then we have to find another solution. Maybe we send a terrestrial team to intervene and we keep one mountain rescuer back, and when the weather opens, then we can go in and out. And there, the most important thing is to be focused and concentrated that you should always only go in when you reach a spot and where you can land. Or you can go back and you can land. So that landing spot, that's your life insurance, and that's you have to keep in mind. And if after a few thousand rescue missions you get this experience, but there is no guarantee, because we also do a lot of errors even with thousands of rescue missions, and that's difficult.
Follows on from that a little bit, really. Just in the UK, both our medical helicopter services and our search and rescue services are not uncommonly limited by bad weather. And so that's a major limiting factor in access to certain locations. Do you know roughly, based on your statistics, roughly how many missions where you would ideally want to get an air asset on scene, you're limited by weather? Is it? I'm presuming it's less because you have more people out in good weather here, whereas in the UK we're a bit nuts.
That's the reason why I'm flying here. We have more than 300 sunshine days here in Zermatt. But I used to be in the board of Rega, the directors, and Rega, they have or they had, or still they have, a big, I would say, task for the future. They want to reach every point in Switzerland 24 hours, regardless of the meteorological conditions. A couple of years ago, we decided to buy AV169, was called the Icebird. Unfortunately, the certification was an issue. And we have to recognize, until today, there will be no possibility that a helicopter, normal helicopter flying in these icing conditions, in these levels. You know, a regular airplane goes up to 40,000 feet, and he's out of these icing conditions. We are always in these icing conditions, so we always have a limitation. And I think there might be 10%, Rega's talking about 300 missions they cannot fulfill because of the weather. In our location, we have the advantage that you can send tough guys who are walking up. Of course, you lose 1 or 2 or 3 hours if you have to go from the valley bottom up to 4,500 meters under harsh and difficult conditions. And yes, there are even risks that a ground team would say, no, it's too risky. So we have to accept that. And I would say we're talking about 3 to 5% max. And here in our area, it's less than 2%, 1% of emissions.
Thank you very much. We look forward to, this afternoon we're going to come and see your workplace.
Yes.
And so I think a lot of the people here will come down. It'll be a pleasure to see you at work.
Yeah.
Thank you very much.
Thanks. That's it.
Break. We'll be back in half an hour to start at 10:30. Okay, guys, thank you so much. So we're going to roll into the last session now. But just before that, I'm going to tell you a little bit about the structure of the rest of the day for us. So for those of you, for your CPD and CME points after this, they should be emailed out to you over the weekend or early next week, and Tom Dolven will be doing that. Just make sure that you've registered and that your email address is correct on there so that you can receive your points. The plan after this session, so we should finish around about midday for this session, and after that we're going to walk down to Zermatt, and we're going to meet outside, I think at 12:45, but Rebecca's just going to come and brief us about the Zermatt. Rebecca, if you wouldn't mind coming up, just because apparently last year when my wig got caught in the helicopters, that was bad, so she's going to tell us not to, no wigs, no toupees, no.
Hello. Yeah, we meet each other at 12:45 in the front of the Hotel Alex, and then we walk together through this heliport around there in the Bronx of Zermatt. And yeah, make sure that you don't wear a hat or something loose. How do you call this?
Lanyard.
Lanyard, yeah. Make sure, otherwise it's getting really expensive. So, see you soon. And
Do you want to tell them what they're going to be
Sorry?
doing? Do you want to tell them a bit about what you'll be showing them?
Oh, yeah. We can do it, yeah. But otherwise, they see you in the heliport.
Well, yeah.
We show you around in the heliport, make sure that you stay in a group because there are always comes helicopters in. We show you around with the rescue bag, with the avalanche gear, the crevasse material, and yeah, what else we have? When we have a helicopter, yeah, but today it's good weather, so maybe there's a lot of missions. We will see. When we have a free helicopter, we'll do a mission, yeah.
Fantastic.
Perfect.
Thank you. Thank you very much. And now, so I know some of you stayed out quite late last night, but we've still got drinks after this as well. So after Zermatt, which should finish around about 3 o'clock or thereabouts, you've got two options. You can either go for a last ski of the day, or you can walk. It's up to you. But we're going to meet at the Servo or Chervo bar, which is a straight walk through town at the bottom of the Senega lift. So you go into the Senega lift, you take the lift up, and then you'll be at the Chervo bar. Or if you're skiing, then just ski down heading towards Senega. So would you mind pointing it out? So it is, where am I looking? Here. So it's just coming down to the end here of the Senega lift. So you can come down to here, you can either ski down or walk through town and take the lift up. And 3 o'clock, it's quite a fun bar. Right, so that leads me to introduce the next gentleman, who I know already very, very well. So Luca Carenzo is a Milanese intensivist and anaesthetist. He's ex-London HEMS, which is why I know him so well, and he was actually very, very good. And you know, they did say he's a bit of a space cadet, but what they meant by that was actually that he is involved in the medical care for the European Space Agency and their analog training program. And he's going to talk to us this morning a little bit about training.
Thank you very much. And good morning, everyone. So a few years ago, I actually attended a public speaking, a medical presentation course. And one of the things I've learned in that course was that as a speaker, you should never apologize. So as I was going through my presentation, I said, oh, I have lots of bullet points. And I think I'm going to read them. But I thought, well, I'm not going to apologize about that. So sorry. Black slide. Well, so I probably need to fix something in my presentation, but while I fix this, why don't you guys close your eyes? Like, close your eyes so you don't see me fixing the presentation, and while you close your eyes, we do a small visualization exercise. What I want you to think is actually try to think the first time you were faced with a medical emergency. The first time you were in charge, or the first time as a student, as a provider, as a paramedic, you entered your workplace, which could be a pre-hospital scene, or it could be intensive care. And now what I want to know, well, I don't want to know, it's a personal exercise. Think how you felt in that moment. And I can probably think that for many of you, at least for me, now you can open your eyes, you felt like you were in outer space. You felt isolated. You felt in a really alien environment. And this is why, and as a novice trainee, or when we have novel colleagues, or we are thinking and designing training for our colleagues, we should think that they and we on a daily basis in our job are faced with a lot of stressors, which are mainly related to the job we do, the environment, and our own psychology. So thinking about some of these stressors, as you can see here, there's a bullet point list. Our patients usually do not have a predetermined storyboard. Even though in simulation we like to have a predetermined storyboard, in real life, well, we would like to change the storyboard, but our patients usually do not have a predetermined storyboard. Often when we face environments, we lose the reference points, especially when we are training and we are novice. We might feel sensory alteration and deprivation. Surely the first time I walked into an intensive care, I was overwhelmed by the lights, the noise, the signals. I could really know exactly how to interpret. I remember one of the first questions was like, how should I interpret all these sounds? I don't really know what that means, and what should I prioritize? And of course, temporal disorientation. We work antisocial hours, we work at night, we work under stress. The ICU I trained had no window. We know that's really bad, but still that's where I train. It had no window. We are confined, and we have we might have limited and restricted communications. Now, it's also required autonomy, because we might be, again, isolated or alone. Now, the interesting thing is that all of these stressors are actually not from a medical presentations. I borrow them from my boss at the European Space Agency, Loredana Bessone, and these are stressors astronauts are faced when they're sent into space flight, and that's what they actually train for, to be confident with. But if we think about a couple of years ago, there is something that even, and I'm not going to talk specifically about this, but let's think about COVID. What happened during COVID? And again, I'm not going to talk about COVID because we all had enough about COVID. But COVID was a novel, alien environment. It was true isolation. There was physical isolation during COVID. We were confined. There was limited privacy. And it required a lot of adaptations, continuous situational awareness, and management of stress. Now, COVID was a bit extreme, but let's think, how is it that we send people to space in this stressful environments, and still astronaut looks very happy, very confident with what they do? Well, we know it's scientifically proven that preparedness overcomes fear. And fear is a very broad concept that we all might have experienced during our own medical practice. So what we pretty much do, and I'm going to briefly talk about what we do in our work with the European Space Agency, is we take astronauts to environments that are challenging. We can't take them to space before space. So what the CAVES program does is we take them to an environment which is unfamiliar for them. We make them familiar to the environment, but it's an environment that still has inherited risk, because again, it's a program that does not have a predetermined storyboards. They can sort of do what they want within certain limits, but they have certain tasks to complete. They have missions, operations to do, but in a very alien environment, which is cause of stress, and which makes people humble, because you're being exposed to a situations you're not familiar, and you are required to be humble about what you're facing. And the key about all this training, which is called CAVES, is actually crew interaction and behavioral skills. So what we stress is human behavior and performance. And on the left, you have a picture of me while we do a dry run for the CAVES campaign in 2019. And what's the equivalent of a CAVES program in medicine? I think our equivalent is simulation. So on the right, you actually see me being very stressed, probably in my most stressful situations, my most stressful simulation, being examined by Dr. Sami Sadek, which we've met yesterday at London HEMS. Well, at the time, I didn't imagine he could have stabbed me at any time, but I'm glad I passed it alive. So when we are thinking about simulation, and this is another picture of one training I had in London, we were exposed, and you should expose when you're thinking, designing your simulation, to the realistic and real environment where all the stressors are actually in place. So London is quite common to respond to railway accidents, especially on the subway line. There are approximately 50 a year, so that makes one a week, so that makes it a 6 months secondment. You will usually respond to 4 to 5 person on the trains. And here we are in a tunnel, it's a link between an active and an abandoned station, but it's still with power, so you have to use all the procedures, all the safety issues. There's a train, which is of course, it's on brake, but it could move. So there are a lot of interesting things, and we're actually simulating extracting somebody from a real train in a real tunnel, because that's what happens in real life. But that, of course, causes a lot of stress to people, and we know stress could be good, stress could be bad, and how do we make people not panic? So this is a picture from SimCup, which is a simulation competition, nationwide simulation competition we have been organizing in Italy for a while. And the key is, how do you get the best teams on the stage to the final phase, and how do you make them sure to get through excellent performance? So one thing I've learned from space is that we've all heard talking about non-technical skills. You know, non-technical skill is that those skills that with technical skills make you have a high performance. But what I've noticed many institutions do not have is what we call a competency model. So yeah, you go to a training course, you go to a simulation course and say, oh, you know, you should learn communication better, you should know leadership better, you should know anticipation better, and so on. But which and how do you apply these skills in your institution? So this is an example, and this is, of course, applied to spaceflight. This is a manual where the competency model for human performance and behavior is applied to long-duration spaceflight. But there is no reason why every institution practicing high-performance medicine should have a defined competency model which defines which non-technical skills I want in my team, how I'm going to train them specifically, and how I'm going to assess them, okay? And this is a very bulky document that actually explains all of that. So in medicine, I had the fortune of working in London. This is a recent paper that we just published, actually, about education. But in the beginning of this, we actually discuss a bit about what are some of the key aspects for high-performance teams and human performance and behavior. So I think simulations, once you have defined your competency model for human performance and behavior, you can train your team using simulation. And there are different things you can do with simulation. You can enhance individual performance, and this is Luca Parmitano on the robotic arm. He needs a lot of performance to be there, but he also needs a lot of performance from in team, because he's operated by somebody inside the station, and actually everything is controlled by a much bigger team, and everything is coordinated. So how can we improve our own performance? Let's do a small, quick clinical case. This is Italian HEMS from the Lombardy region where I work. Now we are all on duty in the Italian HEMS, and you are being dispatched to a case. And the case is, well, you hop in the helicopter, you start flying, you get on your iPad, you have a mail, it's fall from height, and that's all you know. So the question I ask you, and this has been spoiled slightly yesterday by Rich Levitan in the airway talk, is how demanding do you expect this task to be? Just think very quickly. Don't think too much about the task. And how do you feel now this task is going to be demanding? And think, and then think, how able are you to cope with the demand of this task? Okay? And now do the subtraction between the two and keep it in mind. Now you get an update from your dispatch. Well, it's a male 4 from height, but it's actually a 3-year-old, and CPR is in progress. Would have that changed your appraisal of the situations? Surely would have for me, but what we did very quickly was an objective assessment of your cognitive appraisal of stress. This has been extensively studied in elite athletes, and the model defines conditions which are called challenge, which are usually associated with good performance, and threat, which are associated with poor performance. And we're talking about elite athletes. So these are people that know how to play tennis. So let's say you go to the Wimbledon final, you kind of know how to play tennis, but you might still perceive that as a challenge, or you might perceive that as a threat. And that's very linked to cardiovascular responses. This has been studied, because a challenge is usually linked with an increase in cardiac output, as a threat is linked to a loss in cardiac output. but there is extensive sport medicine literature showing that these conditions are actually linked with performance. And what I think is really fascinating, and I think it's the next step for us in research, is that if you're doing, let me use this word which is a bit tricky, psychological manipulation, by changing the way you actually talk with your team, you can change the perceived situations from a threat to a challenge. Again, this is all statistics, it's study, but it's very experimental, but it's extremely fascinating to me. And these are the results. By changing few words in the way that you actually interact with people, you can move a perceived threat into a challenge. We did a small study in simulation again, where the outcome was performance in a simulation. So there's lots of course, limitations. We're not talking about patient outcomes, but team with the higher resources and the higher perceived resources were actually also performing best. The model is slightly more complicated because there's also an interaction between resources and demands, but the key message is that cognitive appraisal is linked to performance, at least in a simulated environment. So once you have this sorted, and I think it's very important as a provider to actually know this, most of what I'm saying in this talk is actually making aware that there are tools that we can use when we're designing our simulation program. What about the team? Well, we're going back to the ESA caves, and why do we put them in caves? Or why do we put somebody in a simulation lab? Well, we have providers from different institutions, different nations, thinking in different ways, using different measures. And it's similar to a trauma team. You have people coming from surgery, from anesthesia, from radiology, speaking different languages and with slightly different agendas. And what you need to do in your program is to make them speak a common language. Teach them those non-technical skills you have defined in your competency model that link with their technical skills are going to make them succeed and exceed and going, let's say, even beyond what they're asked for. So to finalize, what are some lessons we learned from beyond the surface? And beyond is going beyond, of course, in an excellent way. What we learn and what I've learned in London is always, when you're designing your simulation, try to train your team in realistic conditions. Like we went to the tube station and in the tunnel with power, with a train to do the training. I don't have to tell you this is very obvious, but we all use checklists in our reduce your bandwidth, you reduce your overall cognitive bandwidth. This is easier said than done, but team training also should think, how can I build trust and respect your team? Because these are the people that are gonna get on your back. Getting ready for the worst, having plans, you can decide whether you want to plans A, B, C. This is not just about airway. Remember about your shared mental model. And lead by delegation. Once you have all of this in place, you can be a leader by delegation, and your role is going to be just to maintain situational awareness and delegate all the tasks. And finally, something we always do in the CAVES program, and I'm sure you all do, is remember to teach your colleagues to debrief. Not to debrief only what you can improve, but one thing we do at least in CAVES, is debrief every event that went well. John, do I have time for a small video? 60 seconds. So this is my last slide, and I'm going to leave you with a video from ISS Italian astronaut Luca Parmitano, which is sharing his few words about his experience as a leader within the ISS after his last mission where he was commander.
As I've always said from the very beginning, therefore Expedition 61, my role up here is not to issue commands, but it is the role of a facilitator. It's to create an environment, a very open environment where communication flows well so that everybody can perform their job at the highest possible level of confidence and capability. And it's not an easy task. It requires constantly checking with the ground and coordinating with the crew on board what are the best options to perform a task. And we have been very busy with the tasks. As soon as I took command, we started preparing for a series of EVA to change the old batteries, the old nickel hydrogen batteries with new lithium-ion, more performing, better equipped to sustain the station for the next few years. So all the crew has been very, very busy with this series of EVA, unprecedented series of EVAs to change the batteries. From the International Space Station, I'm Luca Parmitano, your space correspondent. signing off.
Thank you.
That's better. Oh, that's better. That's really, really interesting and fascinating, especially the work in the caves. But any questions from the audience? Because I've got one I definitely want to ask you. But one at the back.
Hi, thank you for that great talk. I just wanted to ask you about simulation. In the States, there was a lot of promotion of throwing trainees, especially in emergency medicine, into these sim environments to get them, stressed. But it didn't seem to me often, that at least when it came to airway, that they were providing the trainees with a deliberate best practice to overcome the challenges. So for instance, in the States, very popular is the Lairdale complex airway mannequin, and they would clamp the jaws and do other things that just, anyway, would overwhelm the operator. But it seemed as though people thought that stress in and of itself was good for training. And what I have come to believe is that actually, and I see this in my military experience, is that the best way to train people is actually to focus them on the crisis performance and, like you say, the simple steps, and to train them with that. Like the point of stress training is not just the stress, it's to show them that the engineered steps that you have created work in the stressful environment. And it seems as though a lot of that has been lost in this notion of like throwing people into sim, because we don't give them a best practice engineered, simple stepwise approach. But I was curious about your thoughts on this deliberate practice and incrementalization and step training.
Well, I perfectly agree, because in an ideal world, you would be splitting up your training into small bits where you can actually teach them all the technical aspects. You're gonna make them familiarize with what is actually, let's not call it stress, let's call it, cognitive appraisal and the response to that, which is more nuanced than, stress, because stress can mean anything, can be good, can be bad, can be a disruptor. But what we really want is we want to make, learn their own, let's say, response in those situations and try to control it. And that can be done outside of airway, and then once you sort of have mastered those, you could probably try to merge them. And the other thing I would think is, I'm always a bit skeptical about plain simulation centers that are not exactly reproducing the environment that you work, but that's another story even, because you should simulate what you should, not what you can, but that's a different story. But yeah, that's pretty much, I agree whatever you said.
Yeah, no, I think, and I don't think Spencer is still here from the PJ who was talking, but everything seems to be in the special operator community to teach them that they can do this. It's all this positive reinforcement that the training will get you through the challenge. And that, and I think obviously in sports, that's exactly, the psychology is always confidence building, not confidence crushing. But it seems like sometimes in medicine and the sim centers, all we're doing is stressing them.
We're crushing a lot, yeah.
Yeah.
I was just wondering what your thoughts are on the differences between, say, the space agency team going to the caves and like the HEMS teams. They are very concrete and formed teams, and they are sort of very well cemented as a team, and it doesn't change. However, in hospital, you're often sort of thrown together with a bunch of colleagues that you may not have met before, and how that sort of affects the non-technical skills that within a team.
Well, the reality is that such a course exists to actually create a team, because astronauts, before coming to the cave or before going to the ISS, are not a team. You think you're prone to think that they are naturally inclined to work. Well, they have a predisposition, but there are classic literature tells you there are certain phases of team formations, like you're actually getting together people, then people will be sort of storming, then you need to have some norming before you actually get to production. And it's exactly the same. These are people, we work with all the 5 main space agencies, they submit astronauts. these are people that not necessarily know. Some might be very experienced, some might be junior, never flown. Not necessarily they might be the chief. The experienced provider might not necessarily be the leader of the mission. So they actually need to form a group, learn to form a group in those days, in the first very few days. So it's a dynamic situation, and it's very similar to what happens in the hospitals, because you never know who you, well, in an ideal world, you know, but we know that. And that's why we try to, that's one of the key message from London HEMS as well, is that you should get trained to work with any provider, any paramedic, any doctors, at any conditions, any days, because you're sharing, well, the Shermander model and a competency model, which is, yeah, again, shared.
Yeah, thank you for an excellent presentation.
Thank you.
I do wonder, from the simulation scenarios which you showed, for example, with the London HEMS and the in situ environments, and from those simulation scenarios which you do in your in situ environments in space, how do you do with the debriefing process after those simulations?
From the in the sense of what tools do we use?
Do you use debriefing as a learning tool, or how does it happen?
Absolutely. I still think.
I mean, you know, maybe I think you're aware about this discussion that, you know, there are different debriefing methods. Some of them might be harmful, even like if you use the teaching debriefing method to debrief an acute case, that might be the completely wrong thing to do. But I mean, could you give a little bit of an example how this debriefing looks like? What are your focuses, and how long does it go? And you know, I'm just interested in that.
So, well, one thing is that I don't have an easy answer to this, because my experience is that the best way is to have experienced provider in the briefing, which would be an advice if you're starting simulation, invest in getting people which are experienced in the briefing, whatever that means. Usually, well, the briefing aspect from London HEMS, for instance, and from the ESA is quite different, because in ESA, well, I'm not involved in any of the, you know, training aspect and the debriefing aspect, but there are facilitators that actually go through this, and usually you have internal team debriefing, so teams, you know, are allowed to actually share their own opinions in a protected way before actually being, let's say, have to share their feelings with the facilitator. But these are usually extensive debriefing that last like more than an hour, where everything goes, well, when is reviewed. While usually in HEMS, for instance, what we did is we did a hot debriefing at the end of every job, which is an internal debriefing, let's say in the craft or in the car, just for the team, very quick. And then we did a larger debriefing with all the providers involved, let's say on scene, police, but in terms of the methodology, my perspective now is you should use the tools you're better used, limited with, you know, what literature tells us. So for instance, I tend to use a lot, but again, this is my choice, and you could say it overlaps a bit with feedback and not debriefing. Tools like Delta Plus, where you're actually just giving reinforcements and positive aspects. But a lot depends also on what your formative goal is.
Thank you. I have a question for you. Obviously, when you came to work in London, you come from Milan, totally different language, medical culture, system. And, you know, I always feel it's very difficult for people that come, I mean, I remember one of our Canadian registrars saying, you guys drive on the wrong side of the road. And trying to navigate the streets of London is really hard. And when you've got this group of astronauts from different disciplines, different cultures within their disciplines, different countries, different social cultures, and literally different languages, I think one of the key things is speaking the same language in the team. And as Fion was saying, how do you bring these people together in a team when you might not be in medicine? Is actually having everyone talk that same language, and that's been the ethos of many courses. But what's your experience, and how do you do it with this group of incredibly high-performing individuals?
Well, I think it's a stepwise approach, and the main thing for this specific program, okay, but I'm not saying it might apply to other environments, and to, again, considering the fact that I'm involved in the medical care and not in the designing of the program, is to actually basically put them in an environment that is I would say challenging, but you think challenging could be stressful in a bad way. But as I said in my presentation, which is very humbling. So that's the word that actually my boss uses. Is, you get astronauts which are really A++ top level of the selections of the world, and you put them in an environment which requires you, which is not hard per se, but it requires a lot of humbleness. So you need to kind of stop and think, I'm really small here, and how should I think I should behave to actually make sure we succeed in the mission. I think that's one of the key aspects that lies on deep psychology behind what happens, because that's not something that it's, necessarily openly said, or like, you need to be humble. It's about exposing them to an environment that sort of makes you reflect on how small and how complex the environment is.
I think that's incredibly well put. Any other questions? Thank you very much. It was fascinating. So our next speaker, you will have heard him speak a few words yesterday. He is obviously an international fondue expert, but Vahe Ender is Swiss and American, and when he's not educating about fondue, he's a critical care paramedic in the US with over 10 years of experience in HEMS and retrieval medicine. And that question that sometimes pops up, is this patient well enough to transfer, is going to be something he examines about those patients that are too sick to transfer.
Check, check. Here we go. Thank you so much. Perfect. Thank you so much for everybody coming here this morning, especially now that we've accumulated a pretty impressive sleep deficit throughout the last week here, as well as likely, I think, our ability to use a laser pointer is probably impaired by our activities of last night. But I wanted to just take the opportunity to share the event and the stage with people who I've looked up to over the years. There is a Greek mythology about the three fates, and this may sound potentially familiar to some of you. It is three fates. It's actually three sisters. They were perceived to be the ones ultimately that decided on the fate of all mankind effectively, and actually were perceived to be above the gods. They wielded a power that actually was unmatched by anyone else in any form of Greek mythology. And these three sisters effectively appeared, and with some debates, sometime around maybe the first few days of a child's life, and would effectively appear there at the child's side, and ultimately would decide on the fate of the child's life. One sister would actually keep the scroll and would know the actual length of this child's life, how long this human will live for. The second would dispense a thread of a certain length. And finally, Atropos, the oldest of the three sisters, used a pair of golden scissors and would cut the thread at the time when the life would be ended. Atropos was seen to have the most unbelievable power, the ultimate power, wielding it over not just people, but the gods themselves, which is very rare considering mythology and the sanctity of gods overall. And her power was seen ultimately as inflexible. And this will sound familiar to you because this is something that probably actually appears in many of your respective cultures. I'm speaking of it from the sort of Greek mythology perspective, but the Lithuanians have something similar of a single deity who actually wields the same three powers. It's also in Egyptian mythology as a single deity, but then also in Norse mythology, and that should be, I feel like, over the last week, it seems like half of you are from there. They're called the Norns, and it's something that has kind of bridged across cultures, and we're not sure how, but these three fates ultimately have been able to span their story across all of our cultures, both old and new, and as well as our culture internally here, actually in healthcare, frankly. Because ultimately, this is somewhat of where we find ourselves at times, which is that as an entire group here of extremely experienced providers and clinicians, thoughtful providers, you oftentimes find yourself actually in somewhat of a similar position here where the decisions that you make at times will seem like you are wielding yourselves these golden scissors, and that ultimately some of your decisions ultimately will have somewhat of some inflexibility to them on their own. The challenge actually is it's not just you as the clinician, whether it's in retrieval, which it seems I feel like most of the team here seem to be doing, and in HEMS, but actually it's also happening if you don't work in retrieval. And we have spent a lot of time talking about HEM-specific topics here, but this is actually something which takes place also if you are just a consultant at an outlying community sort of peripheral hospital, or maybe from one academic center thinking about potentially transporting a patient to another facility, and you are now potentially the decision maker. The hardest thing actually about this phenomenon about patients who are deemed to actually be not fit for retrieval or otherwise for primary patients, fit for resuscitation and transport, is that it's somewhat of a black hole. We frankly actually don't really know how often this is happening, because if you work for a retrieval service, the phone call actually simply never really happens. Your phone never rings. There isn't routinely, at least especially in our systems, some phone call made where a clinician at an outlying hospital dealing with the most critically unwell patient that they have potentially encountered are ever able to call you directly as the on-staff paramedic, nurse, or physician to actually ask you, hey, here's the case that I've got. Are you willing to take this on? And so that plays out in sort of the sort of outlying hospital as physicians, and we simply, as retrieval and HEMS professionals, actually ultimately have really no idea when it's taking place as we sit there at our base sipping coffee and making jokes. The challenge actually is that it's not just happening out there, and it's not just a problem for them as consultants out in the outlying facility. It's actually also, frankly, a problem with us. And it's actually somewhat subtle. Let me illustrate it with a case. You are called either as a primary mission or retrieval, whatever the setting is, to a patient who was found down. You actually know very little about the patient. The patient has a Glasgow coma score of 3, has no reflexes whatsoever, and the suspicion is of a devastating intracranial hemorrhage. What's something you want to know about the patient? When you get to the bedside and you do your exam, and obviously you're going to try to identify details about the incident itself, but when you get to the bedside, what is one of the first things that you look at the patient? From a neurointensive care purpose, everybody looks at the eyes, the windows into the brain, as we must say, right? It's one of the first things that we reflexively do. I hear the story, the circumstance is unclear, potentially some prolonged downtime, trying to sort of assess the severity. In the absence of clear radiographic information, one of the first things I do is I look at the pupils. And these are the pupils that you find. One is blown or otherwise, worse yet, they're both fixed and dilated. You've been there. Picture it. The patient is in your resus bay, or the patient is at the bottom of some stairs. You've just landed by helicopter. You open the pupils and they are fixed and dilated. What does that do? How does that drive your behavior in that moment? I think it's easy. If I have a blown pupil, what do I start to think? How fast can I be right now? But if the pupils are fixed and dilated, what do I start to think about? And as I present this case, what are you thinking about? This is all sort of intrinsic. It's inherently within us. And that's normal, because partly through education, but also through experience. But our good friend and wonderful human, Mark Wilson, in his research and meta-analysis actually showed that it's not really actually that much about the pupils. And the first thing that you go to at the bedside is you look at pupils and start to kind of pace yourself and pace your resuscitation and start to potentially have discussions with family in a situation where actually you are lacking a very important piece of information, which is exactly where that damn blood might be. Because he showed in his analysis that it's two completely different injuries depending on where that blood ultimately is, because an extradural, as you call it here, or otherwise epidural hemorrhage, is actually one hell of a salvageable situation, where about over half of them actually will be fine, and many of them actually go back to being able to live independently. Fixed and dilated patients with epidural hemorrhages can do remarkably well. In contrast, not surprisingly, many of the things that fuel our inherent biases, devastating subarachnoid hemorrhages with diffuse extension of blood, obviously has devastating outcomes. But inherently, we have these biases within us. They're within you right now. They're within you the next shift that you're working, whether it's in the hospital or in the helicopter or in the car out there. And we spent a lot of time thinking about how do we sort of form this mesh so that we build our impression of how the patient ultimately will do. And this This is not in any way a complete list to be clear here, but these are some of the things that we reflexively go to. When you try to figure out how sick a patient is, the first thing that you do, your eyes go towards the monitor and you try to see what the damn blood pressure is. We sit there and think, well, what's the pressure? And it's one of the first things, much like the pupils. In the same way, you start to try to formulate your expectations like, well, this is just not going to go well, is it? And they're just not going to do well. And it might be something that's been built and founded off of maybe years and years of experience of seeing similar situations, or otherwise, not at all based off of long experience and large research, but potentially directly by the last case you just did. Maybe that same day, it potentially will alter your decision-making in that moment. And it's within us, it's latent. And it's very hard because ultimately when you start to look into sort of how we form these opinions, we realize that there's actually really very little evidence out there as to how we figure out when a patient is unfortunately futile and too sick for any measures, which ultimately ends up dictating how quickly we end up and how aggressive we end up working here. And these things inherently have their own sort of frailties. And not to break the rules here, but ultimately I'll tell you that a map of 50 is better than a map of 65 in some patients. And in some patients, a systolic of 70 is just as good, if not better, than a systolic of 100 in certain hemorrhagic shock patients. And to highlight this, I think one of the biggest lessons is for if any of you had the privilege of taking care of patients during the COVID-19 pandemic in the first wave, and think about your first patients that either showed up into your emergency department or into your ICU or that you encountered pre-hospitally, there was this bizarre moment where you had cognitive dissonance between a pulse ox that you had been using for 10 years and the number you had in front of you and the patient that you had in front of you. You feel differently about your pulse ox today than you did in January of 2018. And you've had to kind of reconcile that over the years. And historically, we use that much like a blood pressure and much like the pupils as some sort of threshold to figure out when things potentially aren't worth attempting and worth managing. What's the lowest saturation that you have seen in your practice? 50? 40? You've potentially had a patient walk into your emergency department with a family member with a saturation in the 40s. And that is what COVID sort of brought to us in some ways, is it brought obviously pain and suffering and bad, but it also actually highlighted the fact that we build this sort of mesh of our perception of illness and severity of illness based off of things that at times have many shortcomings, such as pulse oximetry. And when we start to look across sort of what we know and what we don't know, we realize that there's these huge gaps because the unbelievable Hugh Montgomery had, in my favorite paper ever and research project, which I can't imagine how this was approved by anybody, decides to get PaO2s on people who are actually ascending up Mount Everest. And it pushed us. When that paper came out in New England Journal, it pushed us to reconsider what we thought ultimately was compatible with life and what wasn't. And he has tried over the years to sort of understand why is it that with these devastating numbers, some are fine, but then sometimes in your hospital, they're fucked, basically. And that disconnect is something that obviously we struggle with when we talk about this patient population. And we all have those cases out there. I'm trying to think of the highest profile case out there for the most prolonged resuscitation, and I can think of Anna Bagenholm, which potentially some of your center, maybe one of you people work at the centers that took care of her, but these patients that we can kind of hold on to, that we are able to say, just look how far we were able to push that. And Anna Bagenholm had the lowest core temperature ever recorded, and effectively was in asystole prior to being put on cardiopulmonary bypass. The willingness to take that on. And it's the situation such as this, a man who's in Minnesota who received compressions and CPR for 96 minutes. And you've had these cases. And obviously we should be careful to sort of jump onto these single individual cases and sort of have these broad implications to attempt resuscitation on everybody. But instead what we should do is we should take these singular cases and realize that we don't really know yet. We're not there yet. In certain there was a paper that gave a one-page summary to physicians working in a hospital. And they were real cases. And it gave an extensive HPI for the admission, the indications for the admission, the clinical course of the admission, laboratory values, radiographic imaging, and subsequently it says the patient goes into cardiac arrest. Do you think that they will survive? And the ability for the staff enrolled in this paper, and this wasn't residents or otherwise people who are new in training, these were consultant level physicians, was a coin toss, 47% reliability. And so it kind of brings up sort of inherently sort of the frailties of our own ability to make decisions when we get towards the boundaries of what's feasible, physiologically speaking. And then there's the fact that there's major sort of shortfalls and gaps in our care that we're not able to account for. For example, throughout the world, there are inherent disparities in care within our systems that we aren't able to account for. We can't explain as to why, for example, women get PCI later in the United States, or why women get CPR less frequently when they have an out-of-hospital cardiac arrest, or why women in Korea get less ECMO. We're not able to account for that. And that's currently sort of the gaps within our systems and our understanding and our perceptions, and sort of the result of inherent sort of biases that we potentially have at an individual level. Many of these things, and speaking as an American, I have to admit, are societal level problems, okay? But at the same time, they are things that are within us, and they drive and they push our decision making. And I'd be remiss to sort of ignore the idea that there is futility in resuscitation. We have to be very mindful, and we learn about sort of the boundaries of physiology here, and we learn about sort of disproportionate expenditure of resources for certain cases, and about the inappropriate sort of sort of complications at times that come with that. But futility is real, yes, but a patient who is unfortunately too sick is not, if we lack currently enough information and an understanding of sort of what the boundaries of what survivability are. And many of you in this room are trying to answer that very question. For that, I think we all thank you for the work that you're doing. And so the question starts to become, okay, so what if we sort of shift our approach? My organization went through that. We have been involved in retrieval of ARDS patients with refractory hypoxemia for a very long time, and we have been trying to sort of figure out and guide our therapy sort of as we shift our system towards meeting these patients' needs. We tried to figure out what we're doing working. When we, in some limitations obviously, took patients that we transported and actually calculated their Apache score, I understand is not a wonderful tool by any measure, but calculated their estimated mortality based off the Apache tools that showed about 30% higher than actually what the mortality frankly was. And when we looked at sort of the risk, because what is the risk ultimately of retrieving some of the most unwell ARDS patients or the most unstable trauma patients out there? What is the risk? The risk is death, ultimately. That's what it is, right? And that's sort of what we fear. 1.7%, 4 out of 239 in our pool, and ultimately we were not able to get ROSC in only one of those patients. That's sort of kind of the what if as we kind of nudge our way closer towards the extremes. And it's not towards nothing, to be clear. I'm not asking you to read these graphs and sort of interpret them. It's to say that every single one of these different slices of the pie was getting the patient to something else. It wasn't to be able to just simply transfer to another place where we pronounce. It was towards procedure. It was towards specialty in certain cases. So what does that require from us? The first thing is that it requires a shift in terms of our own organizational cultures and sort of an understanding that there really there's no one else. And that if you're an organization that is potentially taking on this patient population, you have to shift the culture towards, at the individual level, to say that there is no one else. It is up to us. The hardest thing, actually, is at an individual level. The biggest pushback that you get towards attempting effectively every transport that comes within your system, whether it's primary or secondary, is because you are actually asking a great amount from that provider or the providers that are on the scene in that moment. Yes, we're asking of them things such as the willingness to potentially take on the burden of trauma, of experiencing and going through the cases and potentially losing patients. But really, actually, some of the friction ultimately comes from the fact that you are asking them one of the hardest things, which is that in a world of healthcare where we try to distribute blame and we try to spread sort of the load onto others, when it comes to this patient population, there has to be an individual willingness at the decision-making level of the clinician to take on that weight on their shoulders. And they're willing to, you're asking them to take on all of the good, potentially, the reward of potentially salvaging certain patients, but all of the bad of having to go to M&M and potentially have to discuss and review the decision-making that you make in the snapshot moment in about 15 seconds. Much like London Hems talked about, where they say their decision to cut a chest is made within seconds, but then subsequently the decision is reviewed over minutes to hours and days potentially. It also requires a shift in approach towards going away from perfectionism, frankly. Because one of the hardest things when you find yourself dealing with a patient who is so profoundly sick, unstable, is that you potentially find yourself, especially when having ample amounts of resources, and you start taking on more capabilities, whether it's Reboa catheters, ultrasound, or otherwise transfusion, and start thinking about trying to sort of work your way towards a goal of resuscitation, you potentially find yourself resuscitating into a hole where you're trying to seek for a certain hemodynamic value before you're willing to transport, and you find yourself on scene at a primary mission for 30, 40, 50, 60 plus minutes, potentially trying to sort of salvage a patient from the brink. You have to also get an organizational shift where you learn to cut your losses. And you know that sometimes you have done kind of everything that's sort of reasonable for the circumstances right here, but that at some point, despite the fact that I've got a helicopter full of procedure and full of specialty and expertise, at some point you just have to go. And that's one of the organizational cultural shifts that has to happen. The next thing is, organizationally, you're at a bigger picture, a higher level, you start to have to commit to the hard stuff. And that sounds great, because we can all sit there and say, oh yeah, I put in place a Robono training program in my institution, but it actually comes at a cost. Dedicating the resources of this patient need, of the sickest, comes at a massive cost. The cost is organizational energy and bandwidth. You are not able to do the simple anymore as reliably, as far as you aren't able to invest the time to be able to train for fundamentals as much anymore, because you're spending all of this organizational time and energy and some of your most expert clinicians to impart their expertise onto your other providers, maybe your newer team members or otherwise those who are having to be credentialed on something. All of their time and energy becomes spent on this very small subset of patients. That's not free, I have to tell you. The other thing is that it's not something that somehow, it means carrying a drug and saying, oh, well, now we carry this certain procedure, this catheter, or this drug. It's actually sort of incremental steps that is everything up to the drug actually being put out onto the helicopter, or otherwise potentially the procedure being something that's being able to be carried out by the provider that's on that helicopter. And I think we talk about this here at this conference. Gareth Davies always said, do the basics extremely well. Before you start taking on the thing at the top, which is so appealing, the most advanced procedures out there, you have to do the basics well. And I believe I have said it every single time I've had the privilege of speaking here. And I think multiple speakers have done the same, because it is actually the cornerstone of everything dealing with the patients who are on the extremes. And so it can mean things such as adopting nitric oxide, which obviously studies have shown can improve oxygenation. But what it showed is that you can potentially have this patient now who was originally too unwell and potentially now provide them a bridge towards ECMO. And that's great. But actually, one of the best things is that it potentially saves patients from ECMO. But it comes at a cost, which is this monumental amount of equipment, potentially just as far as the training burden, and as I said, the bandwidth that costs. And so you have to sort of think about managing and mitigating complexity and cutting down on complexity. And on transitioning potentially from a therapy that's billed by the minute in America, and on average will spend $35,000 to plus dollars, is almost as expensive as cardiothoracic surgery, and instead potentially shift to something as simple that you can carry in a backpack, and that might be epoprostenol, to help manage the complexity, or otherwise, equally as important, managing and mitigating the potential cost incurred by your system, the healthcare system as well more broadly, and the patient as well, about allocation of resources as we start to nudge towards the way. And the final things are to let the facts get in the way of your opinions. You have to start to kind of reevaluate things that you really believed were 100% true. This is our area of operations. It's relatively small compared to yours. We cover the eastern half of this state. We do perform retrievals in the adjacent states, but it's a really small area of operations. And we, in many cases, actually would electively go by car or go by ambulance, I should say, very large American-made ambulances that are about 4 times as large as yours. And we would show up at these small hospitals thinking that we were getting there faster by ambulance. And so we studied it, and we looked at 155 referring outside peripheral hospitals relative to the 6 academic centers that we have in Boston, 6, and found that actually there was no configuration of sending hospital to receiving where it was faster to go by ground. You will get to the patient obviously sooner, regardless of whether or not you have to land in a field and then get an ambulance or a police car to drive you to the patient. You'll be faster by helicopter every time, and we were wrong when we originally used to send teams to the sickest patients by ambulance for the sake of time. The other thing is about letting go of your opinions, such as we historically used in-flight RSI as a KPI, key performance indicator, and we would track and we would debrief with cases if they had an incident where they would intubate in the helicopter. We assumed that it potentially was a reflection of poor decision-making. We realized, actually, that in some situations, it is the best procedure that you may be able to do, and we had to put in place an elective RSI program. Our program does patient selection as far as anatomical, physiological difficulty, and the pathology that they have with them, and we will electively decide to take a patient who is potentially comatose with a non-rebreather and an OPA, Goodell, back to the helicopter and electively fly them if we think they are bleeding to death. If the team believes they can perform the procedure and they are bleeding and there is a clinical benefit to taking on the risk of an in-flight RSI, then we do it, and we do so without hesitation and without publishing case reports. It requires you to train, and this is all obviously the final sort of pieces. It requires you to push yourself towards the boundaries of the things that you potentially are comfortable with. I historically was not comfortable. I like the 360 access, much like my European friends, but you start figuring out the way that it works, and damn does it work, because it gets you to the IR suite on the other end for a massive pelvic bleed faster, and that at the end of the day is worth it. It meant other things. We did not transport prone patients up until 2018. It was, if we had a prone patient, which was very rare back then, we would supinate them for transport because we felt that the risk of extubation in transport, which ultimately was fatal from a physiological margin perspective, meant that we were not unwilling to do it. Obviously, we have had to change our approach, much like all of you have done this, but it requires you to be able to and willing to let go of the opinions that you held onto so hard. That's what it means, and it facilitates transports now. We learned from COVID, but we use the procedure, we use prone positioning now regularly for patients who have refractory hypoxemia, where historically it was a initiation of epoprostenol and optimization of mechanical ventilation, and then consulting potentially for an ECMO, either primary ECMO cannulation or a MAD dash to a cannulation team available on the other end. And prone positioning has saved some of our patients from potentially having to do that. The other thing is sort of to say that I'm speaking about the sort of margins of physiology where we really lack a lot of information and we lack a lot of answers. And so we have to sort of think towards the future. There is no predictive tool that's able to figure out when a patient will die in front of you reliably. I will tell you, shock index does not work. Obviously, heart rate variability has not been shown to be reliable. The only thing that has been close enough to tell you with enough time for you to respond with the resources necessary in front of you, whether it's more adrenaline, is end-tidal capnography. And I will tell you from our subset of patients, those that we identify as the most severely unwell that we perform transports for, whether it's primary or secondary, their average end-tidal capnography value is 2.1 kilopascals. That's 16 millimeters of mercury for anyone else who works overseas. That's not a whole lot. And so the AHA recommendation of using that for the detection of cardiac arrest starts to become a little bit less appealing and interesting to me. And that when we review these patients who subsequently have a loss of pulses, their average change in end-tidal value is 4 millimeters of mercury, which is a little bit less than 0.5 kilopascals. Think about what that means on the monitor for you. And so the future opportunities for us is trying to figure out some form of a predictive tool out there that we can use to ultimately be able to catch the deterioration before our eyes and our minds can, with potentially machine learning or something along those lines. And this is really ultimately where when you're hanging on by a thread, physiologically speaking, the eye inherently becomes less reliable as far as the detection of the loss of pulses or deterioration. The final part is that you have to celebrate the wins. You're going to have a lot of losses when you take this transport population on. Many of your patients will not make it. But when you have a win, you have to celebrate it. It will help not just you as an organization, it will help for healing for the provider, because for all of the burden they take on individually by being willing to take care of these patients out there and all the losses that they have, it's important to ensure that you show the value of the weight that is on their shoulders. Atropos didn't simply cut the thread based off of a predetermined sort of rule of whether or not you were a good or a bad person. They did not determine that when you were born on day 3 of your life. They did not know if you would be a good person. And actually, they did not judge you based off of the deeds that you carried out. Atropos and the 3 fates judged you as to how you responded to life's challenges when they came. And that's how they determined the length of a person's life. And I say that's how we determine the value of the work that we do ultimately on our end. Thank you very much.
That's inspiring as all. I was going to say that's inspiring as always. Are there any questions from the audience? Well, I'm finally on now. So I was going to say, are there any questions? If you please pop your hand up any time, otherwise I'll babble on with. There's one here.
This is why I don't do physiology talks, is because it really keeps the questions down.
Hi, thanks very much. And just sort of reflecting on Sami's talk yesterday about decision-making with complex, situations and thoracotomy, and you touched on it there as well, with this need to make a decision with maybe insufficient information, and you could have 2 different clinicians that will come to this different conclusion about the prognostics of the patient. When it comes to making those difficult decisions, how do you see SOPs and guidelines and these things as tools to help us, especially the less experienced, clinicians who don't have that wealth of previous things to fall back on, if you like?
Yeah, I think that it's easy when you have a lot of experience, when you've had those wins, because you can say, hey, look, I've had cases where this works, and so let's do it. It becomes hard if you have 2 junior people. I do believe it's actually very helpful to have top cover if you have a senior clinical top cover that's able to sort of provide some guidance. The problem is that the decisions have to be made very, very quickly, especially in a lot of these cases. And so I think what ends up happening is that we don't have a means to be able to, from a laboratory perspective, if you told me that a lactate of X meant that it was futile or not, well, obviously we'd integrate that into the SOPs. The only things that I have any sort of ability to hang my hat on is really an avalanche burial, frankly, and potassium, right? And that's, I think, one of the few things we are willing to sort of commit to in a hard fashion. And so I think it kind of to really kind of align with what Sam was saying, in the absence of information and clarity and certainty, you then have to be certain. Ultimately, you will have to commit. And we have to allow for that sort of decision-making within our systems. There's no SOP that's going to be able to cover. I think what we should instead encourage is provide them the space and provide a culture that encourages and says, you were willing to take on that weight and that risk based off the limited information available at hand, and sort of have a culture that encourages for the big decisions to be made, the big sort of aggressive procedures potentially to be made in the absence of information. And I think in the void of real granular data right now, I think that's where we're at. I mean, obviously the future is in sort of getting a better sense of these types of thresholds, but the hardest part about studying the sickest patients is that we're able to get the worst data out of it.
Another question up at the front here.
As a doctor in training, I often find that I'm far more optimistic about patients' chances than my consultants are. And I'm like, yes, let's give it a go, let's do it. Do we teach this attitude? Is this something that we learn from our mentors?
I think one of the things about mentorship is actually trying to sort of show that willingness to take on that risk. It's individual personal risk, frankly. Yes, it's not just performing a hoist mission potentially where you're taking on physical risk, but it's also, in America, medical legal risk, but it's also potentially emotional risk. And showing the willingness to take that on as a mentor, I think, obviously is paramount, especially since I have so many consultants who are in the room. I think one of the things that has come out of healthcare, especially post-COVID, is this sort of a sense of nihilism because of a lot of sort of the back and forth debate that's taken place regarding science and healthcare and the sort of erosion of trust of the public in healthcare. And I think one of the things as a senior consultant and as a soon-to-be and future senior consultant is be careful about taking on the nihilism and remember that you've had the wins. It's why you're doing this job now at year 10, 20, 30, 40, or 50. You've had wins that keep you going. Thank you.
Yeah, also, I work mostly in intensive care, but it's a similar. We also have to accept patients and like decide if we want to go all the way or not in a lot of cases. But I think one problem sometimes is we have to make these decisions also based on very limited information, and a lot of times when you make the decision to go on and go all in on this patient, then you tend to also get stuck. And once you have made a decision, then you're stuck for days and weeks and trying to go on, even though it turned out to be futile after the decision. I think there is also a big responsibility for us to step back when it showed that this intervention was futile. But it's a risk when you move that barrier to before the intervention. We have to accept for a certain level of failure and say that we did the wrong decision, we tried, it failed, now we have to end.
I agree with you very much. I think that's why I say mitigate and manage complexity also is not just about the equipment and the procedure and, for example, how small London Hem's kit for thoracotomy is hilarious. But it's, what is it, a pair of scissors, and that's about it, right? Yeah. So I think that's why it's appealing to think about figuring out and being willing to potentially advance care with certain procedures that can get you marginal gains, but at the same time are potentially not something that is very difficult to be able to de-escalate. You know, you're an intensivist. I know you're talking about ECMO. You know, and I think that's one of the hardest parts about ECMO is that it is one of the most burdensome, logistically, clinically, interventions that we are able to do, and it's also the hardest one to sort of to tear back, because in that situation, first we sit on it for a while, and then you just turn the thing off, right? And so it's I think one of those situations where I like the idea about procedures and interventions that, for example, frankly, it's really very straightforward. To cut a chest open and actually put your hand on the aorta is actually very simple. And I think that the burden of sort of the decision to perform a clamshell thoracotomy is actually very, very straightforward and simple compared to something much more challenging like ECMO, which is sort of a long, protracted clinical course. The decision to cut a chest open actually can be done in seconds. The ECMO is actually, frankly, one of the hardest clinical decisions we make in intensive care.
I very much agree with you. I think this pushing of the boundaries is what the people here and the people at home are doing. And if we don't push those boundaries, we don't take that personal risk of falling flat on our face and having everyone else laugh at you saying, oh, you shouldn't have done that, I told you. But actually, as you say, there will be the occasional wins, and that's where we push it forward. But thank you very, very much.
Absolutely. Thank you very much.
So we come to the final lecture, but not the final thing of the day. So remember, 12:45, we'll meet outside here to go down to Zermatt, and before you go up to the heli deck, make sure you secure all of your beanies, wigs, and lanyards. But so Hugh Montgomery, who you've already heard from earlier in the conference, a professor of intensive care medicine from UCLH, who did one of Vahe's, and probably one of my most favourite papers, actually, the Everest expedition. He told me he's going to give us something uplifting-ish to end the conference with, but I'll let him tell you about how we're all going to die.
Good. Well, thank you for staying here. Thank you for your company, your compassion, Mads, thank you. And for all you've taught me this week. It's been wonderful. And thank you to the organisers for the opportunity to talk and deliver, with no disrespect to our speakers yesterday, what is, without question, the most important talk you're going to hear. And the reason I say that is because your lives depend on you listening, and so do those of your children if you have them. And this is a story that we are all responsible for having written. We wrote this story together. And it's important that you remember that you bear responsibility for how that story will also end. Because we've ignored written warnings about climate change. And this is something I know a great deal about. I've been working in this sphere for 24 years now, and I chair a 42-country and over 100-institution annual commission. John Tyndall was the first to point out that gases such as carbon dioxide had a peculiar property. They'd let shortwave radiation through, that's light, and they'd trap longwave radiation, that's heat. And he warned, even then, 1859, that the CO2 we were releasing from industrial processes threatened the survival of our species. But we did nothing. In 1995, the Conference of the Parties, the COP negotiations began, informed by the Intergovernmental Panel on Climate Change as scientists. And they said that we had to peak our emissions. And they said that in 1995, and we didn't. 14 years ago, the calls got more strident. We had to have peaked by 2020, that's 3 years ago, and be cutting. But we did nothing. 12 years ago, the call was getting more strident. We now had to peak by 2015. That's 8 years ago we meant to peak. And we didn't. 8 years ago, it was even more strident. We had to have peaked with only a few years. But look at the change in the language. We didn't just go from we need to peak to stay below 2 degrees, which is what we said 14 years ago, or to avoid dangerous climate change, what we said 12 years ago. But we were meant to have peaked by 2015 if the world was to have any hope. But we didn't. We framed that in a Lancet commission that we published of this multidisciplinary commission, saying very much the same thing. We said in 2008-09 that climate change was the greatest threat to global health of the 21st century. And on that subject of humility, we were wrong. We were very badly wrong, because we were talking about global health and the 21st century. But the issue now is not about global health. It's about our survival. When I say our, I don't just mean people in foreign countries that are poor. I mean yours and your children, if you have them. Because we're not talking about an existential threat to grandchildren or future generations. I'm now considered an optimist when I said a year or two ago that I thought we had 30 years left. I've brought that back. I think we may have 15 to 20, but I'm still considered an optimist in saying that. And the reason is because we've ignored all the warnings and we've continued to behave without any responsibility. And look into your own souls. You've known what I'm telling you now, and you've done nothing, as I have done very little, because this is what humanity burned last year. And when you put that much carbon dioxide into a very small atmosphere, the concentration will go up. If you were to take the world's atmosphere and wrap it into a ball at standard temperature and pressure, that's the size. And the carbon dioxide concentration goes up steeply, and it lasts a long time. A fifth of the CO2 we're emitting today will be cooking our planet in 33,000 years' time. And 7% of what we emit today will be cooking our planet in 100,000 years' time. And that's why, because we've ignored the warnings, we've gone over the cliff edge now. Let's not think about global temperature rise. We've managed to raise the surface temperature of our planet by about 1.12 degrees from pre-industrial times. But think of the energy it takes to raise the temperature of an entire planet by that much, especially when 92% of the energy has gone into the oceans. How much energy? Since 1950, we've trapped around 6.7 billion Hiroshima bombs worth of energy in our atmosphere. And we thought last year that we were trapping 5 Hiroshima bombs of energy a second, an extra 146 million a year. The data that came out on the 23rd of December from NASA says we've got that wrong. We're now trapping around 8.7 Hiroshima bombs worth of energy a second, or approaching 300 million a year. And that's driving up temperatures from this Goldilocks temperature we had in the Holocene for around 12,000 years that allowed us to flourish, with this massive spike in basically the last 50 years. So temperatures are going up. We're melting Arctic sea ice. We're melting land ice. The Greenland ice shelf itself losing 1.1 million metric tons of fresh water a minute. And you add that water, and from all the other land losses, to thermal expansion in the ocean. And sea levels are now going up by a centimetre every 2 years. And that rate is accelerating. If you add energy to an atmosphere, you get weather. If there was no energy in an atmosphere, there'd be no weather at all. The more energy you add, the more extreme weather events you're going to get, and the more extreme those events are going to be. And this attribution study statistically looks at the last multitude of very extreme weather events, and you'll see some of them in blue were definitely statistically not due to human activity. And there are some in grey where we're not sure. But the red ones we know statistically were due to human-induced climate change. And that's basically all of them now. And you remember these, and you are familiar with them. Let's go back to the Northern Hemisphere winter, just pre-COVID. Australia ablaze. And this is the first of the positive feedback loops. Just that fire, in just one season, in just the east of just one province, in just one country in that 1 year, raised global greenhouse gas emissions by 2.6%. But it wasn't the only fire. Siberia is ablaze. California is ablaze every year. The Amazon is ablaze. But there are 3 times as many fires in the rainforests of Angola and Congo than there are in the Amazon. The bottom left, Indonesia ablaze. And let's just think through to we've gone from winter 2019 through to 2020, then 2021, when Canada was ablaze. And that year too, the whole of Europe was ablaze. The end of that year, Colorado was ablaze. And so we rolled into January 2022. Massive heat waves with record temperatures in South America, in Australia. We had these huge temperature rises beginning in Spain in the spring. By the spring, the joke in Pakistan was that if you died and went to hell, you should take a blanket because it was so hot on earth, it was cooler in hell. China was experiencing record temperatures as well. Japan, record temperatures. This is the whole globe. And Europe. Those of you who are in Germany will be familiar with this picture of the Rhine, as we'll come to shortly, dropped to 36 centimetres in depth on the 18th of July. But it was Italy, that's the Po River. It was North America, that's Lake Mead. And then, of course, the United Kingdom got hammered with record temperatures. We predicted we had a 50% chance of reaching in 30 years, and we got them 18 months after that prediction. But it isn't just the fires, and it isn't just the heat waves. This was going back to summer of 2021, the floods on the Belgian-German border. That was Germany. That was London that summer, when one of the major floods we had, we couldn't admit to 3 hospitals because of flooding. This was the tens of thousands dying in China. Those are the iconic pictures of the New York subway. And so we rolled on, though, to British Columbia just before Christmas. 18,000 displaced. Just before Christmas, approaching 100,000 displaced in the end in Malaysia with record flooding. Africa, early part of 2022, highest density rainfall ever recorded in southern Africa and KwaZulu-Natal. Highest density rainfall ever recorded in Spain. Florida, massive surges. Over a third of Pakistan underwater last year. Venezuela in October, 5 rivers breaking their banks. Over 500,000 people displaced in Nigeria at the end of the year. And then we come through to this winter, North America, these sorts of pictures coming from the oscillation of the jet stream. And then we come through to January, where these look like this is great news and great fun, isn't it? But it's not. Temperatures in Bilbao should have been 10 Celsius, and they were 25 Celsius. Same record temperatures elsewhere, followed by the flooding in California. The point is that you're all getting used to this. It's like Mike Tipton's talk about immersing yourself in cold water. Once that fast response of shock has gone, you're not aware of it anymore. And you're all getting used to the fact that this chaos is normal. It's not normal, and it doesn't stop here. Remember the statistics I gave you about future energy gain. What this tells you is that 1.1 degrees Celsius temperature rise is not safe. It's catastrophically dangerous because it's going to continue because of the duration of the half-life of CO2. Worse still, we thought we were on track for 5.5 Celsius with continued emissions. But the bad news is, from just pre-Christmas, we're currently on target for 10 Celsius. Now, 1.1 will likely destroy your lives and those of your children. 10 degrees Celsius would end life on Earth as we know it. And the problem is, for the reasons I explained, and because of the hysteresis effect or reversing effect, even if we stop emitting right now and we draw down carbon dioxide at industrial scale, which we can't do, climate change impacts are going to carry on for thousands of years now. Now, you might say, well, I don't really care about a few thousand years, but you should care about your own lifetime and that of your children, because look at what the IPCC report said in 2021. And I will read it in case you can't see the full slide at the back. Species extinction, widespread disease, unlivable heat, ecosystem collapse, and cities menaced by rising seas will become painfully obvious before a child born today turns 30. So this isn't going to happen after 30 years. This will have happened by then. We know that 18% of the Earth's surface area currently occupied by humans will be uninhabitable in the next 30 or so years, displacing nearly 3 billion people who will die or move. And to that you can add another 2/3 of a billion who will be underwater. And they'll move long before they're under the high tide mark. That's half the current world's population moving in a matter of a few decades. If people were to survive, if your children were to make it through, there wouldn't be much point, because these temperature levels, as this paper in Science showed, will be culminating in a mass extinction event to rival those of Earth's history. Remember that the Permian lost 96% of all life on the planet. That sounds bad, but it's worse, because a lot of this modelling is not done taking into account non-linearities. Our emissions aren't going up linearly. We think they are because we're at the right-hand side of this graph. They're going up exponentially. And we've now triggered 9 positive feedback loops where temperatures will continue to rise no matter what we do. The first of them is the fires. We talked about that just now. The fires releasing carbon dioxide, which traps more heat, which desiccates the land more. The dry air can hold more moisture, more fires. But it releases carbon monoxide, which takes out hydroxyl radicals in the lower stratosphere. And that would normally be depleting methane. Methane is 83 times as powerful a greenhouse gas as is carbon dioxide in its first 20 years. So those feedback loops feed on each other. We're losing ice and snow, which has a surface albedo effect, reflecting light back into space. That loss and the exposure of dark soil and ocean has doubled the rate of Earth's energy gain in just the last 14 years. And meanwhile, we're releasing methane from carbonate rocks, from frozen methane hydrates, and from fermenting wetlands. There are other positive feedbacks too. The blanketing effect of smoke is an insulator. That raised the average surface temperature of Australia in those fires by 3 degrees Celsius. And the black soot in the lower stratosphere absorbed heat and raised the lower stratospheric temperatures by 0.7 Celsius over Australia just from those fires. Meanwhile, we've depleted our rainforests, which would normally be a sink, such that all of the world's rainforests are now net emitters of CO2. Just look how many fires, what we're losing to fires every minute, 16 soccer pitches every minute now. And it's worse still than that, because weather doesn't change gradually. Weather changes suddenly. We get binary states from one change, and things change dramatically. Now, one of those binary state changes you need to understand is about polar warming. The poles, north and south, are gaining temperatures around 3 times faster than the global average. And that warming can suddenly accelerate in what are known as Dansgaard-Oeschger events, or DO events. And here's one in the middle there, about 38,000 years ago, well recognized, where temperatures rose by about 10 to 11 degrees Celsius in a matter of a decade or so. This paper from Nature was saying that we have probably triggered a DO event here, but look at its magnitude. Temperature rise at the poles of potentially 35 degrees Celsius in a matter of only a few decades. Now you might say, well, let's hope that doesn't happen, Hugh. These are just projections. The problem is the evidence says it has happened. This was March the 21st last year, when you'll see that Antarctic temperatures were 40 degrees Celsius above normal, and those in the Arctic were 30 Celsius above normal. And that's really bad, except the following day on March the 22nd, temperatures in the Antarctic were 47 Celsius higher than normal. Last June, average temperatures in the Arctic Circle were 32.5 degrees Celsius. An average is normally 13. And this is causing massive loss of ice, which itself can trigger other dramatic effects. So the Thwaites Glacier alone is losing around 1.6 million litres of fresh water a second, contributing around 4% to global sea level rise. But it's anchored to the continental shelf by pillars of ice. And when they melt and fracture, which we think they will within the next few years, there'll be nothing to hold that glacier back from sliding into the ocean on lubricant meltwater, producing a very sudden dramatic rise in sea level. And the temperature rises there are also dramatically changing, becoming very unstable. So this is the Greenland ice dome blue line average record across the year. This was last year, very erratic temperatures with a sudden spike in the very beginning of September. That spike pushed temperature up by 20 Celsius in a matter of a few hours. There was melt across a third of the ice sheet. That much was lost just on the 3rd of September. And indeed, 20 billion tons of ice were lost that just one weekend. That's 7% of the annual ice melt in one weekend. And that's bad, and you'd rather hope it wouldn't happen again. The bad news is that was the second year in a row that had happened. We're going to change ocean currents. This is the AMOC, or Atlantic Meridional Overturn Circulation, which is drawing in warm water from over here in the Pacific, bringing it around the north of Australia. Up past Great Britain here is the Gulf Stream, which is why our winters are relatively warm compared to those in Newfoundland over there. If that changes, we get very, very, very severe impacts on global weather systems. The bad news is, as these papers from Nature Climate Change and so forth show, we're now at a point very close to a critical transition. We don't know when it will flip, but there you have the papers. If we continue as we are, same timescales, the next 25 to 30 years. Meanwhile, the jet stream is moving. The jet stream is a high-altitude, high-velocity river of moist air at the junction between warmer southern air and colder Arctic air. And it's moving because of the Coriolis effect of Earth's spinning. If that moves, which it will, we're going to have severe impacts on moisture distribution. Again, we're looking at the next 30 or so years. There will be no rainfall in the Iberian Peninsula, so there won't be any rain in Portugal or Spain, rendering them largely uninhabitable. But all of that moisture is going to get dumped into northern Europe. So if we've had storms and floods before, they're going to be very much worse, unless it coincides with the AMOC switching off, in which case we'll be having tens of meters of snow dumping on us in London. And the jet stream is becoming unstable in the summer. Here are the velocity gradients going around the globe, trapping hot air between them in a sandwich. And it was that ring of fire of hot air that was trapped that caused those temperature rises everywhere, South America, Australasia, Europe, and so forth. Now, it's not just climate scientists who've been putting this warning out. The military, I'm a fan of in many regards, because they often just take a pragmatic view. They weigh up the evidence and they decide what the response is going to be in an unemotional fashion. So this is taken from an unredacted Pentagon report from 2003, 20 years ago, postulating what would happen without rapid, immediate decarbonisation. You've got to love the use of language. The result of inaction could be a significant drop in the human carrying capacity of the Earth's environment. They were talking about billions of people dying, and they were telling us that 20 years ago, when everyone else was also warning, and we did nothing. The World Economic Forum, not the most liberal and left-wing group of individuals, beginning of last year surveyed their members. What are the greatest threats of the next 10 years? Climate action failure, extreme weather events, biodiversity loss, human environmental damage, and the resulting geoeconomic confrontations. And those geoeconomic confrontations are beginning, because we are already starting to see how civilization is going to unravel in the next few years. This was the Po River. It supplies 22% of Italian agriculture. The net result of heat waves and the loss of water meant that its grain production was down by nearly 40% in Italy last year. Fruit and milk production by the end of the year was down by 20%, to a total economic impact in Italy of 3.8 billion euros last year. It wasn't just Italy, though. France's corn production was down by nearly 20%. China had a severe harvest impact. India had a massive loss as well. Syria's barley crop completely collapsed. We've got famine in Sudan. We've got famine in the Horn of Africa. But because of impacts in Ukraine, compounded by these climate change impacts, there isn't any grain to supply them. And the aid agencies had to cut aid supply to those areas by 40%. There were impacts on power. Italy gets about 20% of its power from renewable resources, and around half of that comes from the Po River, and its hydroelectric generation was gravidly impacted last summer. In France, electricity generation was badly hit because it's 56 nuclear reactors, which rely on cold water to cool them. And if there isn't any water, or if the water's too hot, you can't run the reactors. Gas pipelines, even running subsoil, get hot. Boyle's law tells you the pressure will go up, which means you can only transmit less gas. So our gas transmission between Britain and Belgium, our interconnector, was badly impacted. And you might say, well, lots of sunny weather would have made up for it with solar panels. But when you get solar panels to get hot, they don't work very well. They become 25% less efficient. The impacts on the Rhine economically were very significant. As I said, on that particular date, the depth dropped to 36 centimetres at Kaub, which meant that you had to put the contents of one barge into 4, greatly increasing the cost of movement of those goods. We saw the same in China. 66 large rivers ran dry across China by August of last year. So there's no way of disguising it. We are absolutely down to the wire now. And in the last few minutes, we've got to talk about what to do about it, because the answer is it's down to you and me. We together, and me, all of us, have failed to take the responsibility that we should have taken. We've known this story, you have known this story, but you and I have done nothing. Now we have to. It's down to us. The reason is that the politicians aren't going to solve it. We can talk about why another time. But here is the atmospheric concentration of CO2 with major climate negotiations, which have done nothing at all. Here are the last 26 COP negotiations, or 27, which have done nothing at all, because in fact the gradient is going up ever more steeply. In fact, after COP26, last year we had record-breaking emissions. Why? Because when you hear that the Conference of the Parties has reached an agreement, you need to work out what the contract is. So here it is. Here are the key points that were agreed. They agreed to recognise the importance of the best available science. That's helpful. They agreed to welcome the contribution of the AR6 Working Group 1 of the IPCC. That's helpful. They agreed to invite the IPCC to present more data. They agreed to express alarm that the temperature had gone up and to stress the urgency of enhancing ambition. None of that takes a single molecule of CO2 out of the atmosphere. And bear in mind, the Paris Agreement said that if we were to have a 50% chance of staying below 1.5 degrees Celsius, we had to cut emissions in half by 2030. Right? That's 7 years away. Half the emissions when they're still going up at an exponential rate. What would happen if we didn't? Quotes, any further delay in concerted global action will miss a brief and rapidly closing window to secure a livable future. Not a nicer future, one in which you or your children might still be alive. And yet, at last year's COP negotiations, the aim to have peaked in 2025, still too late, was completely removed. When we look at the statement of President von der Leyen at the outcome, COP26 has not delivered on a commitment to phase down fossil fuels. You and I thought that's what the negotiation was for. But no, the Secretary General was saying, we need to drastically reduce emissions right now, but this is an issue the COP did not address. They didn't even discuss cutting emissions at the last negotiation. We're going backwards. And it's worse because every time data come in, we've underestimated the impact. Paris thought we had until 2030 to have halved emissions, but we now know from data on January the 5th that we have a 97.5% chance of breaking 1.5 degrees next year. So this is your call to arms, and you are the right people to do this because you are the people who come to a conference like this. You are the people who step up to the plate. You're the people who open the chest and clamp the aorta and go the last mile. You recognize when you have to lead, and we've had lots of talks about that leadership. So let's just not walk out the door and forget about it, because it's your responsibility. I'm going to stop with some very quick things of personal action because it's helpful, but you need to make a note of them mentally or on your iPads or your phones. And you need to do all of these things now. You've got 45 minutes before we meet to go to the air ambulance, and you can do this online. You need to move your bank. If you're lucky enough to have a country with a bank that doesn't invest in fossil fuel extraction. In Britain, if you are here from Britain, you can use the cooperative bank. Triodos has just launched a carbon non-investing fund. I'm not sure if yet it's good. I can't tell you whether the user experience is good. I can tell you the co-op is no worse than any other bank to bank with. You need to vote with your money. We need to move around 3 trillion a year, so that's around 4% of global domestic product, into renewable generation. And we don't have control over that. But you have control over it with what you spend your money on. And you cannot keep buying. We must stop just purchasing. And when we are purchasing, we have to purchase from companies that are doing the right thing. Because when we do, it will make them profitable. And it will make the baddies unprofitable. And the pension and hedge funds will flow at scale. You need to move your energy supplier to one that is genuinely 100% renewable. I'm parochially British. In Britain, that gives you a choice of companies like Octopus or Good Energy. I don't have shares in either of them. But they're 100% renewable. You can do that online from Switzerland if you're British and you haven't done it. Do it now. If you turn your heating down in the winter by 1 degree, that's saving 7 to 11% of emissions. Turn it down by 5 degrees, you've halved your energy bill. You've halved the emissions you're responsible for. And as Mike Tipton knows when we're on calls, he always knows when I'm on a Zoom call from home because I'm wearing a hat, a scarf, and about 5 layers. But why would I pay to heat my flat? My energy bill last month was £7. £7. And that included hot water, because I don't heat my hot water either, because I don't have to. You need to engage others to act. The advertisers will tell you that every one of you is respected or loved enough by a minimum of 7 people. So there are 7 people who love or respect you enough to do pretty much anything you ask them to do. So find those 7 people and tell them, I don't care whether you believe me, I just need you to do this because you love me. Change where you invest and your savings are. Change your diet. Very difficult in France, isn't it? Where the choice is basically meat or meat most of the time. Because greenhouse gases coming from agriculture could be a very quick win for us. Cows belching methane produce a huge amount of greenhouse gas, but so does the whole supply chain that comes from cows. So my drug of choice is caffeine. And if you look at the coffee beans that get grown, that get transported, that get roasted, that get milled, get processed, that get turned into instant coffee, someone melts sand to make a glass jar, puts a plastic lid on it, ships it halfway around the world, shoves it in my supermarket, I go and buy it. Water is pumped and chlorinated to my tap. I boil my kettle using electricity, even if it wasn't 100% renewable, let's say, and I make my coffee. The carbon footprint of the splash of milk I add to that is more than all of that other carbon footprint because of the belching cows and because you've got to flash pasteurize the milk. Travel. I'm not going to name and shame people, but you can't fly. You can't do it. It's a monumental amount, or if you are going to do it, you've got to work out where your saving comes from. So if I'd flown here with Mike, we'd be responsible for around 3.4 metric tons of carbon dioxide between us. And it's pretty hard to find out where you save 3.1 metric tons between 2 people from the rest of your carbon footprint. So if you want to take the flight, you're going to have to work out where you're going to make your other savings, and it's really hard. The good news, for those of you that took the Eurostar here, is that Eurostar is, until the French border and a little bit beyond, runs on nuclear energy, which is essentially carbon-free. The carbon footprint of Eurostar is about 8 grams of CO2 per kilometre, and walking is 6. So I don't think it's such a bad trade to have taken the train to come here. And you need to vote politically and financially in all that you do. The final bit of good news is that healthcare, us, we can do this. Because we're 5% of global emissions. And you might say, well, Hugh, even if we cut by 50%, we save 2.5% of global emissions. You're talking out of your rear end. It won't make any difference. But we're 12.7% of global domestic product. And if you add in products made by a company like Reckitt Global Health, who make Dettol and Durex, and you count those as health products, you're way over 20%. So if we decarbonise our healthcare system, the people from whom we purchase, we write it into our contracts for procurement and so forth, it makes a massive difference on global financial movement. Partly as well because we intersect with around 70% of global supply chains. The steel we buy for the buildings is the same as the steel that goes into our needles, glass for ampoules and glass for windows, cardboard boxes for our drugs are probably made by the companies that make cardboard boxes for cornflakes. If we act, we can change the world. We need to do the same things in our hospitals. We need to move our hospitals immediately to 100% renewable and ideally generate more. And in fact, we're leading an initiative in the UK for these things called power purchase agreements, where basically a bond gets raised and your hospital owns the wind farm. And that gives them dramatically lower bills and certainty on pricing for the next 15 or more years. Why do we poison people with unhealthy food in hospitals? And by people, I mean staff as well as patients. We could make a change. And we need to think carefully about the value of what we do. We do too much stuff in medicine that doesn't help, and we need to stop doing it. And we need to change the procurement. If you talk to the companies, which we've done, we had 50 CEO-level C-suite members in a room last February, they're all saying, please write it into the contracts. If you write in the contracts and say, we have to reduce our emissions, scope 1 to 3, immediately, we will. But it's very hard to get it past our shareholders if there's no competitive advantage. So just tell us, you can't bid for the contract unless you do this, and we'll change. So that's where I'm going to end. Your scientists, your rational human beings, you've heard these data before. You just probably haven't listened to them because it's been convenient to you not to, because it will disrupt your life to listen. But you now have to. You have to for selfish reasons, even if you really don't care about anyone else. And if you are old enough and you have children of your own, there isn't a single parent in this room that wouldn't die for their own children. And I'm not asking you to die for your children. I'm asking you to sacrifice some things for them. Because together we wrote the story. Together we can write the ending. And it's your call. Do you want to be the villain of the piece? Do you want to be the hero of the piece? And if you're old enough to remember David Bowie, let's end on a quote from him. We can be heroes forever and ever. What do you say? Thanks for listening.
That was incredibly sobering and important. Questions at the front?
You can use mine if you want. Oh, there you are.
No, but intersecting this with Jean-Louis' presentation before about the future of medicine, and there's a lot of high-tech stuff going on, all of which consumes a lot of energy.
Yeah.
Is this a bad way of evolution of healthcare?
Yes, in a nutshell. It's not bad in itself. If you look at, if there were no other existential threats, the application of ML, for instance, across the board is the quickest way to save money, improve outcomes, and improve efficiencies. It will be utterly transformative from everything from drug target to drug design using AlphaFold, to the chemistry that will develop the new drugs, to their deployment, to the trial data, etc. It would make a huge difference. But we won't be here to use it. It's the wrong focus. And we were talking a little earlier on about, I don't know, the value of our jobs. I go to work and I love it. I love the juniors that I have there. They're just the most amazing people. I love diagnoses. I like the reward I get from helping a patient live or giving a patient a good death. But it's meaningless, isn't it, against things like this? And that's where we just have to be focusing. I'm not suggesting that we will stop work tomorrow, but this is the #1 priority. And we've heard nothing but this for the last 4 days. We have to act urgently to save the life. We have to prioritize what we're doing in the right sequence to do that. And here is your number one priority by miles. And you can't have a moral offset by going, well, I save lives for my work, so someone else will have to solve this problem. We can't do that.
Strange question, but would you see the population of the world compared to the emissions? Is it sustainable with?
Well, it's a very good question. So, what is the population of the world currently sustainable? No, not in the way we're living. We've exceeded the 5 planetary boundaries upon which we depend. So we certainly can't, as a population of 8 billion, live in the way that we're currently living. That we will all die if we continue to do that, because we've exceeded 4 other planetary boundaries as well. We've got to differentiate, though, who's causing the harm. If you live in rural India, your carbon footprint's 0.13 metric tons a year. If you live in Luxembourg, it's 24 tons. In parts of North America, it's 46 tons. In England, it's around 12.8 tons. So it depends who you are. If you're poor, your carbon footprint isn't very much. It's us. We're the problem. And we need to live different lives. And I'm not suggesting we bomb ourselves back to the Stone Age to do that. And it is a challenge. If you go online, go and do a carbon footprinting. It takes about 20 minutes, and you'll find it's really difficult. It's quite easy to get rid of the first 50%. Bloody difficult to do the bit after that. That's the bit you change by your political vote and by your dollars that you spend, or euros. But yeah, at this population, no. And we're adding, bear in mind, another billion to the population every 12 to 14 years. It took us 540 million years of multi-celled life to reach the first billion, and it took 127 years to add the next billion. It took 33 years to add the next billion, and now we're adding, say, another billion every 12 to 14 years. And no, we can't do that if we all continue to live as we do.
Thinking about sustainable healthcare and the carbon footprint of healthcare, what are your thoughts on helicopters?
Well, I don't know. I can't, as much as I am trying not to preach by telling everyone exactly what it is they have to do, I don't know the answer to that question. Because if it was my remaining son whose life could be saved by your helicopter, I'd want the helicopter there, of course I would. The number we've got to bear in mind is, we need to be at 0 now. There is no such thing, by the way, as net 0. Net just means we will offset some way with magic pixie dust the emissions that we leave behind. And the magic pixie dust doesn't exist. Last year, industrial carbon capture and storage took out 1.8 million metric tons of CO2 against a net balance of 59 billion tons. So we just have to look at them and say, what is it in what I do at work and at home where I can go 50% down by Sunday, which you can. You could do that by Sunday. Most of us could do that by Sunday. And then the rest of it, I think, just has to be working within the systems in which we work to drive the change. And, HEMS people, helicopter motors, you people, have enormous public respect. I have enormous respect for you. I think you're extraordinary. And you've got a voice that you could be using to change things. People will trust you in a way they won't trust other people. So maybe that's the thing to do. Fly your helicopters, but use your voice.
So we haven't been very good using our voice. And often it's like we are busy, we don't want to recognize what's happening. And for a long time I thought, what can I do? Started a presentation, a few slides, lost it again. Are you willing to share your slides? Well, I think a few of those slides would just make it easier. And another second question is, I don't want to tell you where I come from. I took a very long flight. I will be traveling by train in Europe. What do you think of offset programs? And you gave some recommendations. Are there good programs that you could recommend?
Okay, so first question, I will share slides to selected people. I'd ask you not to pass them on. The danger is that slides get presented by people who don't understand them or don't understand the data. And I've got, without blowing my own trumpet, I've got 24 years of immersion in this, and there's a lot behind it. So you just have to be cautious. Of course I'll share them. If you email me, I will. But just don't pass them around willy-nilly, because you'll find that people will start putting out confusing messages. Offsetting, it's very nice of you, but I wouldn't bother. It makes no difference. Most of the offset programs plant trees. Well, some of them actually don't. They say, oh, well, we'll invest in the future to reduce other things that would have put emissions up. That's not the same as taking emissions out. Tree planting, if you plant a broadleaf European tree, is around 5.9 kilograms of CO2 in a year. So if I had flown here, let's say 1 metric ton, that's 1,000 kilograms in an hour. Work out how many trees I'd need to plant to do that. To offset current global emissions, you'd need to plant 3.5 times as many trees every year as there are on the entire planet at the moment. The reason for carbon offsetting, if you want to do it, is just as a way of behavioural change, because it costs around £17.80, so call it €20, to plant 1 broadleaf tree at cost from sapling to planting. And if that's, say, 6 kilograms, and, well, let's call it 5, that's 200 trees. If you were to offset your ton in a year, 200 times 20 is €4,000. That's what it would have cost you to offset your flight, even if you were to offset it over a year. So by all means do it, because it's quite a good way of focusing your thought processes, isn't it? Say, do I want to add €4,000 to the price of this? No, probably I don't. And I'd encourage you to use the train to come here. It's lovely. I got 11 hours of uninterrupted email and other things done, and it's beautiful.
Hugh, thank you very, very much. That was just... Oh, sorry, was there one more question? Sorry, I didn't see the hand.
Hi, from the back of the room. I find it very important that we change on our personal scale, but it's also very important to change the healthcare practice. So if you mentioned 5% of the global emissions come from the healthcare system, and actually 50% of them come from anesthesia care. And we have a lot of anesthetists here, and we can do a big change in just abandoning Desperane, for example. If you haven't done it in your clinic, do it tomorrow. It's a very easy measure. You can do it. It's no problem. We did it in our clinic. It worked perfectly, and nobody is complaining. And it's thousands of tons of CO2.
Yeah, and we could all look at our practice. Gloves and aprons. You know, there's so much that we do, but there are systemic things. 74% of UK healthcare deviates from standard guideline and best practice, because we all like to add in just one more CT scan, or maybe we'll just do another bunch of extra blood tests. So if we stick to what we know works, we can make a big difference there too. But finally, of course, we all need to be advocates for public policy. And again, we were talking about this earlier on. It's nuts, isn't it? The data we've heard. We've got 30,000 people shoot themselves every year in America. That's just crazy. That's a public health epidemic that needs to be solved. I was horrified by the HEMS data of the number of stabbings in London. One of our celebrity chefs, Jamie Oliver, has been campaigning for years to say you shouldn't be able to sell a knife with a point on the end, because its only purpose is to penetrate something, which is usually another person. So we need some proper public health measures here, which we could also advocate for, because if we took out a lot of those stabbings, because all the knives were round-ended, and if you were caught pointing one, you went to jail, that would make an impact, I imagine. A few less flights, I guess. Thanks.
So that concludes the lecture series and the lecture part of TBS 23. Traditionally, this is a point at which I should be thanking the speakers and the organisers for doing this. But I'm not going to do that, because I think you get enough plaudits as it is already, because your talks have been fantastic and the organisers have done a great job. But the people I'd really like to thank are you, the audience, here and at home, who've listened to these, because you're the ones that will go out and change practice and change more than that. So thank you for coming, and we'll see you outside at 12:45 to head down to Zermatt.